you Sugeng Rawuh, which means a very warm welcome to each and every one of you. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Namo Buddhaya, Salam Kebajikan, Om Swastiastu, blessed be upon us. Distinguished guests, ladies and gentlemen, please allow me to introduce myself. My name is Tis Maniar, and this is such a great honor for me to be here as your Master of Ceremony for today's prestigious event. First and foremost, please allow me to extend our gratitude and warm welcome to the Honorable Mr. Ali Gufron Mukti, President Director of BPJS Kesehatan. Good morning, sir. Mr. Alexander Marwata, Commissioner of the Indonesia Corruption Eradication Commission, who joined us virtually. Good morning, sir.
Selamat pagi.
Selamat pagi, Bapak. Our speaker that present here in the room, in person, Mr. Basan Gart, Additional Chief Executive Officer of National Health Authority and Mission Director of Ayushman Bharat Digital Mission. Good morning. Ms. Lily Krisnawati, Director of Healthcare Service Assurance of BPJS Kesehatan. Ms. Pianghatai Ingun, Claim and Medical Audit Specialist of NHSO. Mr. Mundi Harno, Director of Supervision, Inspection, and Interinstitutional Relation of BPJS Kesehatan. And also good morning to our speakers that join us through online today, Mr. Marcelo Abiramia Saitano, Secretary General of International Social Security Association, Mr. Lorenzo Lanteri, Healthcare Police Advisor of SINAM, Mr. Tom Verdort, President Director of European Healthcare Fraud and Corruption Network, Ms. Seung Mi, Team Lead Associate Research Fellow of Health Insurance Review and Assessment, Mr. Pahala Nainggolan, Deputy for Prevention of Corruption of the Indonesia Corruption Eradication Commission. Our moderator that also in this room, Mr. Doni Hendrawan, Mr. Somil Nakpal, Ms. Natalie De Wolf, representative from Social Security countries who join in person and virtual, guests of honor from the ministries and institutions. Distinguished guests, ladies and gentlemen, on this beautiful day, December 8, 2022, we gather here at Pelataran Heritage Borobudur, Central Java, Indonesia, for the International Seminar on Fraud in Social Health Insurance Prevention, Detection, and Elimination. May I have a round of big applause, ladies and gentlemen, from each and every one of us for this prestigious event this morning. Thank you. And before we begin, first of all, let us express our gratitude to our Almighty God for the blessing so we can gather here today in a healthy condition. Secondly, ladies and gentlemen, on behalf of the committee, we would like to thank everyone for taking all of the efforts and time to attend our today's agenda. Thank you. It is truly an honor to have you all here and welcome you here in the beautiful Magelang City. For today's conference, ladies and gentlemen, we provide interpreter channel for channel number 1 for English, channel number 2 for Bahasa Indonesia, and channel number 3 for French. If you need to leave the room, please keep the equipment at your table. Thank you. Distinguished guests, ladies and gentlemen, Indonesia is the 4th most populous country in the world, with current population is 208 million people as of November 2022. On January 1st, 2014, the government of Indonesia launched JKN, Jaminan Kesehatan Nasional, or National Health Insurance, which aims to protect the Indonesian public from the shock of sudden health crisis. The JKN program making significant progress from covering only 46% of the population in 2014 to 89.76% at the end of this year. Since its launch, JKN has undergone several improvements to enhance its 3 main pillars of JKN, which is population coverage, revenue collection, and healthcare purchasing. However, JKN also faces challenges. Fraud and waste in healthcare insurance system has become a big issue to deal with. Combating healthcare fraud takes a collaborative effort with providers, members, and stakeholders to improve the detection of fraudulent and abusive activities within the program. While this is a big topic in insurance industry, we'll take a step back to discuss what health insurance fraud is, what it does to the sector, and what to do to address it. With this event, ladies and gentlemen, we hope that we are able to produce a valuable insight and mutual understanding to prevent, detect, and eliminate the fraud in social health insurance. Distinguished guests, ladies and gentlemen, to commence the International Seminar on Fraud in Social Health Insurance, Prevention, Detection, and Elimination, we would like to invite President Director of BPJS Kesehatan, Mr. Ali Gufron Mukti, to deliver the welcoming remarks.
Very good morning. Very good morning. Selamat pagi, salam sejahtera, Om Swastiastu, Namo Buddhaya, salam sehat. Honorable Mr. Alexander Marwata, Commissioner of the Corruption Eradication Commission, our speaker that present here in person, Mr. Basan Garg.
Bahasa Inggris lah. Rina tuh ada BPJS.
He is the Additional Chief Executive Officer of National Health Authority and Director of Ayushman Bharata Digital Mission, which already covered 600 million people approximately. Applause for him. Thank you. And Ms. Lily, who is on the way. Ms. Piang Tai Ingun, thank you. And Mr. Mundiharno, our Director of Supervision, Inspection, and Interinstitutional Relation of BPJS Kesehatan. Our speaker that joined us through online, Marcelo Abiramia Kitano, the Secretary of ISTA, and Mr. Lorenzo Lanteri, the Health Care Police Advisor in Hinam, Mr. Tom Fedong, Mr. Seung Mi, and Mr. Pahala Nainggolan, and our moderator, Mr. Doni Hendrawan and Somil Nakwa. And of course that we are happy here because we would like to congratulate and welcoming to our guests from Philippines, from Myanmar, from Brunei, also from Vietnam, from Cambodia, and also World Bank, Ajay Tandon, and all the groups. Thank you very much for your attendance here in this very important meeting. Let me just read, in Indonesia we call it pantun, it is some kind of poem. Borobudur is one of the great destinations with its great view of the rice field. We proudly welcome speakers, moderators, and delegation. It is a pleasure for us to have you here. Enjoy sunrise in Borobudur with a beautiful view. Don't forget to take selfie with boomerang. In this wonderful moment, let me welcoming you to the heritage of city of Magelang. Ladies and gentlemen, first of all, again, I would like to thank you for your commitment to come very far away to this beautiful village near Borobudur. And of course, all the representatives from social security countries who join in this person upon our virtual and guest honor from the ministries and institutions, ladies and gentlemen. Welcome to Magelang. As you know that Magelang is one of the regencies located in Central Java province, Indonesia. It is rich in historical relics, one of which is the Borobudur temple. I'm not sure whether you have already visited Borobudur or not yet, but it must visit. A masterpiece insurance system is becoming big issue to deal with along the run of its provision. It is a kind of phenomenon to put attention at and to find the solution, since it keeps alarming and becomes a threat. It might increase the cost of healthcare and may harm patients either by giving them unneeded care or by withholding needed care. The issues of corruption and fraudulent claims remain of the biggest challenge the sector continues to face, and there is an increasing use of technologies, innovation, and to combat this. Ladies and gentlemen, as we know that it is normal as the human being would like to have benefited it and would like to have more money. But the problem is sometimes as the doctors have different type of train when they were in the schools. Long time ago, I was the dean of the Faculty of Medicine, and we always, say to our students that you should give the best services to the patient to save the life without considering the cost. But the health insurance side always thinking that resources always limited and scarce. So therefore you have to make more efficient. So there is contradictory thoughts. Therefore, of course, this topic is very interesting in the real situation, how we dealing with this. One should survive and save life and without considering at any cost. But at the same time, because of limited resources, we have to be more efficient and efficient. As I told you that in Indonesia, for example, our operational costs always reduce in terms of percentage, and it is the performance of Ministry of Finance. You know, if they can cut operational costs, it means good things. But what about BPJS Kesehatan and other insurance agencies? In KINEM, I think our representative from KINEM can tell us, have around 85,000 staff. Indonesia and serve around 70 million people. In Indonesia, we have only 8,500 staff. In KINEM, 85,000, we 8,500. And in KINEM should serve around 70 million people. In Indonesia, we serve 247 million people, more than 3 times. So, of course, then with very limited number of staff, how then we detect? We know that there is potential fraud. That is our new innovations, and we have to work to learn together how to deal with this. Ladies and gentlemen, of course, the fraud is the big topic in the insurance industry, and we'll take a step back to discuss what actually health insurance fraud and what it does to the sector, what to do to address it, by organizing this international seminar involving expert speakers and experience on social security in various countries under the theme of the fraud in social health insurance, prevention, detection, and elimination is as an effort to improve the quality of social security implementation and in the global situation of threat of the global recession. It must be very tough. It also aims at strengthening national and international anti-fraud networking and strengthening the JKN fraud prevention team within BPJS Kesehatan in this country. We are aware that social health security program has provided great benefits to people, all countries, and of course it is our obligation as the administrating body to maintain the quality of services and program sustainability. Looking up at the data of our national health insurance program accomplishment so far, in Indonesia, we already achieved 90% or around 247 million coverage. But of course, the main issue is not only the coverage, but effective coverage, where, when, whatever the reason, they can have access without financial hardship. And of course, that the main challenge faced by Social Security health Social Security for such a great number of population, like in India and also in other countries, Philippines, I think also big, and with challenging geographical barriers in only one scheme in one single administrating body. One of the efforts to maintain the quality of service and sustainability of the program is to pay attention issues related to fraud and implementation of health social security. The existence of quality and cost containment standard is very helpful in preventing fraud, and of course innovation on digital ecosystem development is very important. We are aware that fraud in social security can be committed in all lines of participants, in primary care, in hospital, officers of social security administrating agency itself, providers of medicine like pharmacies and medical devices, as well as members of companies who pay contribution. Therefore, concrete steps are needed by creating a system for preventing, detecting, and eliminating fraud. Ideally, the handling of fraud is carried out very strictly, as we know that in several countries the treatment of fraud has been going very well, but in other countries it is not going so well. Starting from detection, handling, investigation, and prosecution by law enforcement and regulatory publicity. This implementation is certainly not easy. It requires awareness and involvement from all parties and, of course, regulatory support from the government. What needs to be watched out for it is fraudulent behavior is an act that can be contagious. That is like COVID. So COVID's already almost gone, but fraud is growing. If the perpetrators of fraud are not detected and are not prosecuted, then it will be an example for other parties to follow, to commit it. In Indonesia, we have started handling frauds, which include regulation as an implementation protection and a system for detection and also in using new technology, digital ecosystem, which is currently as the backbone, the establishment of fraud prevention team. I think that is under leadership of Mundi Harno, and the imposition of the sanction. In the past, because BPJS Kesehatan is always deficit, but now it's already positive, although many people wanted always negative. Why? Especially when we examine the COVID, they want to be negative, but BPJS is always positive. But the problem is that, again, if fraud is not detected. So tackling and preventing fraud in healthcare is a crucial important to the Social Security administrating body and also absolutely to the country and to the people. I strongly support the emphasis today's conference focusing on raising awareness, comprehending challenges, and methodologically approach developing fraud prevention, fraud detection method by utilizing new technology, optimizing collaboration and cooperation between agencies and organizations as a means of combating fraud in social, especially health insurance program. In my stand of view, by having good understanding of fraud, technology use optimization, and collaboration between institutions will make a very appropriate guide for handling and tackling fraud in social security. Lastly, once again, I believe that this seminar represents an important and collaborative step in this process, and I know that it will produce valuable insights and ideas. We are looking forward for any prospective step in tackling fraud and quality for sustainable healthcare system. And before I closing, please allow me to read our pantun again, the poem. Magelang is the city of hospitality, with the people that offer warm and batik to wear. The seminar has run successfully. Thank you very much and see you next year. I think that is all, and again, thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, can we once again have round of big applause for the welcoming speech by Mr. Ali Gufron Mukti as President Director of BPJS Kesehatan. Thank you, sir. Distinguished guests, ladies and gentlemen, our next agenda for this morning is the keynote speech from Commissioner of the Indonesia Corruption Eradication Commission, who joined with us virtually. Allow me to invite Mr. Alexander Marwata to deliver the keynote speech.
Ya, terima kasih.
Yang saya hormati Direktur Utama BPJS Kesehatan, Profesor Ali Gufron Mukti, dan jajaran, para narasumber, serta peserta seminar internasional BPJS Kesehatan. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, Shalom, Om Swastiastu, Namo Buddhaya, salam sehat dan bahagia untuk kita semuanya. Bapak Ibu sekalian, KPK menaruh perhatian yang besar pada sektor kesehatan karena besarnya anggaran kesehatan yang dialokasikan APBN, yaitu mencapai 5% dari APBN. Pada tahun 2022, alokasi pada anggaran kesehatan mencapai 256 triliun atau setara dengan 16 miliar dolar Amerika. Sektor kesehatan juga berkaitan langsung dengan hajat hidup masyarakat banyak. Dan pada sektor ini peluang korupsi sangat besar karena sifatnya yang tidak pasti serta tingginya ketimpangan informasi antara pemberi dan pengguna layanan kesehatan. Ada kecenderungan pasien menerima begitu saja tindakan-tindakan dan obat-obat yang diberikan para medis sehingga menimbulkan tagihan yang sangat tinggi. Beberapa kasus besar dalam bidang kesehatan yang pernah ditangani KPK antara lain misalnya kasus korupsi pengadaan alat kesehatan, kasus dana kapitasi, kasus korupsi vaksin flu burung, hingga kasus jual beli jabatan pada pejabat di Dinas Kesehatan. Bapak Ibu sekalian, sistem jaminan kesehatan nasional atau sekarang lebih dikenal masyarakat dengan nama BPJS Kesehatan adalah program nasional yang mulai diterapkan pada tahun 2014 dengan menggunakan mekanisme asuransi kesehatan yang bersifat wajib dengan tujuan untuk memenuhi kebutuhan dasar kesehatan masyarakat secara layak. Program JKN ini penting karena asuransi sosial bersifat nasional dan memberikan manfaat yang komprehensif dengan premi terjangkau, sehingga dapat digunakan di seluruh wilayah Indonesia. Dalam perkembangannya, JKN yang masih berusia muda ini menghadapi beberapa tantangan serius, mulai dari mutu kualitas pelayanan kesehatan, kurangnya fasilitas dan tenaga kesehatan, hingga permasalahan anggaran. Berbicara soal kecurangan pada sektor kesehatan, munculnya JKN telah merubah peta tren korupsi di sektor kesehatan dalam beberapa tahun terakhir. Sebelum tahun 2013, pengadaan alat kesehatan, pembangunan infrastruktur, fasilitas kesehatan, dan obat merupakan top 3 objek yang paling banyak dikorupsi. Tetapi setelah adanya JKN, objek terjadinya kecurangan bergeser dengan penyalahgunaan jaminan kesehatan. Meskipun secara nilai jumlahnya kecil, namun karena dilakukan secara masif dan sistemik, kerugian yang dihasilkan juga cukup besar. Data di Amerika Serikat misalnya, yang sudah memiliki undang-undang terkait healthcare fraud dan membangun sistem pengendalian kecurangan kesehatan dengan cukup baik saja. Di sana ada gugus tugas gabungan dari Kementerian Kehakiman dan Kementerian Kesehatan. Kebocoran akibat program asuransi masih cukup tinggi, yaitu berkisar antara 5 sampai dengan 10%. Serupa dengan situasi di Indonesia, potensi kecurangan JKN di fasilitas kesehatan yang terdeteksi beranjak naik dari sekitar 175.000 klaim pada tahun 2015 dengan nilai kerugian sejumlah 440 miliar rupiah menjadi lebih dari 1 juta klaim pada tahun 2016. Dengan pengawasan dan pengendalian kecurangan yang belum berjalan dengan baik di Indonesia, bisa dipastikan jumlah kebocoran akibat kecurangan pada JKN juga sangat tinggi. Oleh karena itu, sejak awal perencanaan kebijakan JKN pada tahun 2013-2014, KPK sudah ikut melakukan pendampingan perencanaan kebijakan JKN ini hingga tahun 2022. Peran KPK dalam upaya menjaga program JKN ini adalah melalui fungsi pencegahan, yaitu pemberian rekomendasi perbaikan pada JKN dalam hal manajemen dana kapitasi, perbaikan tata kelola obat, perbaikan tata kelola alat kesehatan, hingga menyusun regulasi terkait penanganan kecurangan dalam program JKN ini. KPK juga menjadi pionir dalam menginisiasi terbentuknya tim bersama pencegahan dan penanganan fraud JKN yang dimulai tahun 2017 hingga tahun 2019. KPK juga terus melakukan upaya pencegahan melalui pembangunan ekosistem yang berintegritas bersama asosiasi profesi kesehatan, asosiasi produsen alat kesehatan, dan produsen obat, sehingga mengurangi risiko kecurangan serta tindak pidana korupsi. Bapak Ibu peserta seminar yang saya banggakan, terakhir, KPK mengucapkan terima kasih dan berharap melalui seminar ini tercipta sinergi dari para pemangku kepentingan terkait untuk bersama-sama menjaga berjalannya program jaminan kesehatan nasional, baik melalui pencegahan, monitoring, maupun penindakan atas penyimpangan yang masih terjadi, sehingga tujuan untuk menghasilkan pelayanan kesehatan yang prima bagi masyarakat dapat terwujud dan menjadikan Indonesia yang lebih sehat. Terima kasih, demikian saya sampaikan. Wassalamualaikum warahmatullahi wabarakatuh. Om Santi 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 Om. Shalom, selamat pagi.
Thank you, Mr. Alexander Marwata, for the keynote speech this morning. Excellencies, distinguished guests, ladies and gentlemen, we will continue our agenda this morning with special talk about how to prevent and encounter healthcare fraud and corruption on a global level based on guidelines on error, evasion, and fraud in social security. Please welcome our speaker for this topic, Secretary General of International Social Security Association, Mr. Marcelo Abi Ramia Saitano.
Professor Ali Mukti, distinguished members and participants, it's my honor to speak at the opening of the International Seminar on Fraud in Social Health Insurance, Prevention, Detection, and Elimination, organized by BPJS KZN. Unfortunately, I cannot be with you in person. Nevertheless, I am pleased to send this recording to highlight the importance of the topics discussed in this seminar. These topics are key to the ISA member institutions and the work addressed by ISA, and shows how ISA supports social security institutions. Let me start by expressing my sincere gratitude to Professor Mukti and BPJS KZN for its continuous active leadership and participation in our activities, enabling us to achieve the goals of the ISA. With the immense support provided since 2017 by your predecessor, Dr. Ives, and by you since 2021, The ISA has addressed major healthcare-related challenges, and the Technical Commission on Medical Care and Sickness Insurance, the TC Health, played a key role. I am sure that this will continue as the ISA enters the 2023-2025 triennium. I am pleased to share with the participants today that the Bureau of the ISA has unanimously approved your continued designation as the chairperson of the ISA TC Health for the new triennium, as proposed by the ISA president, Dr. Mohamed Azman, at the meeting of the ISA Bureau held in Marrakesh, Morocco, in October this year. So, on behalf of the ISA president and the General Secretariat, I'd like to congratulate you on this appointment and express our deep gratitude for your engagement and dedication to the work of the TC Health during the new triennium. Health has become a priority on international agenda, even more so with the COVID-19 pandemic. The TC Health aims to identify key policy and administrative synergies within the overall social security system to ensure adequate benefits, improved coordination and collaboration, and ultimately, better health for all. The TC Health is dedicated to the sharing of good practice and innovative strategies on major topics, such as responding to the changing needs of an aging population, improving resilience, health insurance systems, coverage, and service quality. The TC Health has organized various ISA webinars to share country experiences and the views of key international partners. It also contributed good practice to our article series, including on medical deserts, sickness benefit schemes, and preventing and tackling fraud in healthcare through emerging technologies. As we enter a new triennium, let me share with you the topical priorities for 2023-2025. First, the transformation and innovation in management and service delivery. Second, social security coverage for a diverse workforce. Third, protecting and supporting people during a changing life course. Fourth, social security supporting resilience and sustainability. The talk of financial sustainability will be considered across all these four priorities. The theme of this international seminar is important for almost all priorities, and in particular for financial sustainability and effective coverage. Financially sustainable healthcare systems require that scarce resources are used in an efficient and effective way. And fraud is an important threat for healthcare systems in this regard. It can seriously damage healthcare finances and consequently lead to lower quality care, and it is therefore important for social security institutions to engage in appropriate counter-fraud activities. Strategies and solutions to support policymakers and social security institutions in preventing and detecting fraud are also fundamental in guaranteeing the right to health for every patient. As healthcare provision depends on the efficient combination of financial and human resource, it requires appropriate behavior from healthcare providers and administrators. Essential elements of counter-fraud strategy include risk assessment, measurement of fraud, developing an anti-fraud culture within the organization, prompt detection of fraud, pursuit of sanctions, and measures to seek redress of funds lost due to fraud. Investing in ICT is crucial to detect, monitor, analyze, and develop tailored responses to tackle fraud in healthcare efficiently. As an international setter of professional standards, the ISA worked in 2017 with its global membership to develop the ISA guidelines on error, evasion, and fraud in social security systems. Stressing the importance of an integrated and holistic approach to prevent, detect, and fight errors and fraudulent behavior, whether it's from the institutions or for the beneficiaries. These guidelines are based on a risk assessment approach and cover all major risks involved. In addition, the TC Health provides the important input into the recent revision of the ISA guidelines on administrative solutions for coverage extension by drafting a new part on defining a regulatory strategy to ensure the sustainability of healthcare and build confidence across the population. The revised ISA guidelines were published during the World Social Security Forum and are the basis for service and knowledge production that support social security organizations that are facing health coverage issues. Let me close by emphasizing that meeting complex challenges in social security, such as combating fraud and error, can benefit tremendously from the exchange of experience of things that work and areas that require improvement. These unique platforms and networking opportunities bring together the global social security community to share, learn, interact, and be inspired by innovation. It is member institutions like BPJS Kesehatan that enable our global association to be dynamic and effective. So, on behalf of the ISA and its members, I'd like to thank Professor Bukti and BPJS Kesehatan and wish you all an excellent international seminar and very, very fruitful discussions. Thank you very much, and I hope to see you soon. Thank you.
Distinguished guests, ladies and gentlemen, welcome to the first panel discussion of the International Seminar on Fraud in Social Health Insurance, Prevention, Detection, and Elimination. For your information, ladies and gentlemen, our conference today will be divided into 3 panels discussion, where each panels will be given 45 minutes of time to convey, including Q&A session. Our first panel discussion today will outline the matters on challenges and methodological approach to define and quantify healthcare fraud. Before we proceed, allow me to introduce our distinguished moderator this morning. She is coordinator of the Technical Commission on Medical Care and Sickness Insurance, TC Health, and of the Special Working Group on Rehabilitation. Please join me to welcome our moderator, Ms. Nathalie De Wolf, to the stage. The time is yours.
Thank you very much, and thank you very much for your warm welcome, of course. And we have received already a lot of precious information in the welcoming speech, but also from the Eradication Commission on Corruption. And it's true that, of course, we want to make Indonesia healthier, but we want to make the world healthier. So today, in the first panel, we will, of course, address the very difficult topic on what are we talking about? How can we define fraud? Do we all mean the same when we talk about fraud? Or are we talking about errors, abuse, waste, corruption? So how can we even benchmark if we're not sure that we're talking about the same things? So this panel will talk about the importance and the challenges on how to define and quantify fraud. And we are very honored to have as speaker that Ms. Pangatai Ingun, and please may I invite you to join the So Ms. Pangatai Ingun is Claim and Medical Audit Specialist of the National Health Security Office in Thailand. And thank you very much for joining us here. We will also have the distinguished speaker from France, with Mr. Lorenzo Lanteri. He's the Healthcare Policy Advisor at CINAM, the National Sickness Insurance Fund in France. He's not with us today, but he has pre-recorded his intervention, and we will have a look at it just a little bit later. But we also have two important panelists who will join the discussion. The first person will be Mr. Zoom Thun Duc. He is the director of the Center for Medical Claim Review in the Social Security Vietnam. And I thank you very much in advance for your precious contributions. And of course, Mr. Hasnal, the head of division of the Anti-Fraud, Ethics and Integrity at SOCSO, Malaysia. So we will have the first speaker will be the speaker from France through the pre-recording. It will be then followed by Ms. Panga, yes. And then we will open, of course, the panel with the two distinguished speakers from Vietnam and from Malaysia, and then we will address your questions with the Q&A. So let us first start with the intervention of Mr. Lorenzo Lanteri. Please, thank you.
Bonjour à tous, je suis désolé de ne pas être avec vous aujourd'hui. Je suis sûr que vous allez vivre un colloque passionnant sur un sujet aussi important que la lutte contre la fraude. La première question qui doit venir à l'esprit quand on décide de quantifier et d'évaluer la fraude, c'est pourquoi est-ce qu'on le fait? Le premier intérêt de l'évaluation de la fraude est de donner un ordre de grandeur, une échelle à laquelle on peut se rapporter. Il faut bien que l'on puisse rapporter les montants des préjudices détectés à la fraude elle-même. Cela permet de mesurer l'efficacité des outils de lutte contre la fraude. Ensuite, il est important de connaître précisément le montant et la nature de la fraude à laquelle nous sommes confrontés, afin de savoir où concentrer nos efforts. Qui fraude ou abuse, de quelle manière, et quel est le préjudice financier pour l'assurance maladie. L'évaluation de la fraude est assez récente dans l'histoire de l'assurance maladie. Pendant longtemps, on se bornait à constater l'impact financier des fraudes détectées. Nous n'avions pas d'évaluation chiffrée de la fraude. Mais en 2020, un rapport a pointé du doigt le fait que l'assurance maladie, tout comme la branche retraite, n'évaluait pas ces fraudes. En outre, le gouvernement a fait dès 2018 de la lutte contre la fraude, aussi bien dans les sphères sociales que fiscales, une de ses priorités. La priorité du gouvernement était de disposer d'une connaissance plus fine des fraudes auxquelles la sécurité sociale peut être confrontée. Et en premier lieu, l'assurance maladie qui, je vous le rappelle, verse chaque année 230 milliards de prestations. Il faut tout de même préciser que nous ne partons pas de rien en matière d'évaluation de la fraude. Nous avons déjà développé un outil appelé la cartographie des risques. Cet outil permet d'identifier les risques de fraude par type d'acteurs ou de prestations. Comme vous le savez, nous traitons avec une variété d'offreurs de soins, avec chacun des spécialités et des modes opératoires différents et spécifiques. Cette cartographie se divisait donc en grandes catégories de professionnels de santé, comme les infirmiers, les transporteurs sanitaires ou les médecins, ou par grande catégorie de prestations, comme l'allocation d'invalidité ou l'allocation pour arrêt de travail liée à la maladie. Néanmoins, cette méthode était insuffisante car elle ne nous permettait pas de faire de l'évaluation chiffrée de la fraude. C'est pourquoi, dès l'automne 2020, l'assurance maladie a engagé des travaux pour mieux évaluer le préjudice financier lié à la fraude. Ces travaux se sont d'abord appuyés sur un benchmark avec les autres administrations de sécurité sociale françaises, telles que l'assurance famille, la Caisse de sécurité sociale des agriculteurs ou encore l'assurance chômage. Ces travaux de comparaison ont permis de faire un premier constat, celui qu'il existait autant de méthodes d'évaluation de la fraude que d'organismes de protection sociale. Chacun a ses propres définitions de la fraude et chacun a ses propres méthodes d'évaluation. On est sur des sujets très statistiques à ce niveau-là. Nous avons ensuite poursuivi nos travaux à travers un benchmark européen et nous avons pour cela travaillé avec le EHFCN, European Healthcare Fraud and Corruption Network. Ces échanges avec les autres pays européens nous ont montré qu'il n'existait pas de méthodologie commune d'évaluation de la fraude. En outre, nous avons aussi découvert que nous n'étions pas si en retard que cela et que beaucoup d'autres pays européens débutaient à peine leur réflexion sur le sujet. Ces travaux de benchmark nous ont amenés à 3 conclusions suivantes. La première était qu'il était inutile de calculer un taux unique. Cela n'avait pas de sens compte tenu de la diversité des acteurs et des prestations. La deuxième était qu'il fallait fonder les travaux d'évaluation sur l'existant et notamment repartir de ce que nous avions en SWOT, la cartographie des risques. La troisième conclusion était qu'il fallait adopter une définition assez large de la fraude en englobant aussi bien les fautes, fraudes, erreurs ou abus. Nous avons à ce moment-là avancé nos travaux sur 2 types de catégories de risques, ceux relatifs aux assurés et ceux relatifs aux professionnels de santé. Grâce à la méthode statistique rigoureuse dont je vous épargnerai les détails techniques, l'assurance maladie a pu chiffrer la fraude poste par poste. Nos premiers travaux d'évaluation ont porté sur la complémentaire santé solidaire. Cette prestation est une aide pour les assurés les plus modestes pour prendre en charge le besoin de soins qui n'est pas couvert par l'assurance maladie. Elle concerne plus de 7 millions de personnes. Les résultats de l'évaluation montrent une estimation du préjudice financier compris entre 1,22% et 8,7%, pour des montants respectifs de 25 millions d'euros et de 176,5 millions d'euros. Il faut rapporter ces chiffres au regard, évidemment, des 2,47 milliards d'euros versés par l'assurance maladie. Le taux de fraude de 1,22% est celui qui correspond où les ressources dissimulées s'élèvent à des niveaux qui ne sont pas forcément très importants, alors que le taux de 8,7% correspond à des petits montants de ressources non déclarées. D'autres travaux d'évaluation ont porté sur les infirmières. Les travaux ont fait apparaître un taux de préjudice financier compris entre 5% et 6,9%, soit 286 millions d'euros et 393 millions d'euros. Ces montants sont encore à relativiser au regard des dépenses de 7,5 milliards de l'assurance maladie sur le poste infirmier. Nous avons ensuite répété cette méthodologie pour les médecins généralistes, les transporteurs sanitaires en 2022. Nos prochains travaux porteront sur les pharmaciens, les masseurs-kinésithérapeutes et les maisons de retraite. Notre objectif est d'évaluer la fraude là où le volume des dépenses de remboursement est important, mais aussi là où les risques de fraude sont grands. Alors c'est le moment de revenir au pourquoi de mon introduction. L'objectif des travaux menés par l'assurance maladie est de mieux connaître les préjudices financiers par type de risque afin d'améliorer la détection et surtout les sanctions. Cette évaluation permet aussi de développer la prévention, car on identifie les failles du système et on verrouille les possibilités en amont. Voilà, je vous remercie.
So thank you very much, Mr. Lorenzo Lanteri, for sharing the precious information from France and how difficult it is and how recent, in fact, some initiatives have only been developed. Mr. Lanteri also mentioned that he's addressing it not only the benchmark on a national level, but also on a European level. And he mentioned the European Healthcare Fraud and Corruption Network, which is a non-for-profit association based in Belgium, in Brussels, that works since 2005 and with European institutions countering fraud in the healthcare sector. And they have been doing a great work on the lexicon of infringements and the typology of error, fraud, and corruption. But we will address this later during the interactive discussion. So, without further ado, I would like now to give the floor to Mr. Piang for our intervention on challenges and methodological approach to define and quantify healthcare fraud, the case of universal healthcare scheme in Thailand. So please, Ms. Piang, the floor is yours.
Good morning, ladies and gentlemen. It's a great honor to be join this warm welcome seminars and to share our experience in Thailand about the challenges and methodology approach to define and quantify healthcare fraud. Before going to this issue, I like to share a brief history of Thailand to achieve the USC. Okay, next slide, please. Thank you. And Thailand have spent more than 40 years to achieve USC. We developed the health, not only the health infrastructure, and also legislation until we achieved the USC in 2002. Next slide, please. We are now have the 3 public health insurance schemes, including the civil servant benefit scheme or the CSMBS scheme for government employee and their dependents, the Social Security scheme or SSS scheme for private employees, and the Universal Coverage Scheme or USC for informal workers and the rest of Thai citizens. These 3 main schemes also different in budgeting, policies and management. For the NHSO, we are responsible for manage the UC scheme for about 70 million population, covers about 70% of Thai citizens. However, in order to harmonize these 3 schemes, we have national committees and related working groups to discuss and on specific issue in order to harmonize the benefit package, policy and management among these 3 schemes, including the audit process. Next slide, please. Why we have to do the claim audit? Important, right? All claim and reimbursement are required to be audited in order to reflect good governance and to ensure transparency and quality of our reimbursement, to verify collectiveness of reimbursement, to strengthening accuracy of medical record keeping, and the most important thing is to prevent and detecting fraud. Next slide, please. And the audit system in our office consists of accounting audit based on financial audit and medical care audit based on the critical guideline from doctor, or we call CPG. And in order to have to improve quality of claim and reimbursement, we also do have pre-authorization to use as an approval process before starting some specific of care or treatment that have very high cost, and also do pre-audit before payment and post-audit after payment. This type of audit, we may use any of the following method, right? The coding audit, billing audit, quality of care audit, or medical record audit. Next slide, please. This diagram just to show you the evaluation of audit system of the NHSO. We start to have audit system in 2006, 4 years after we achieving USC. At that time, all claim data had been digitalized So it's easy for us to do the coding audit. At that time, the main claim and reimbursement are based on capitation and DRG for inpatient service. So that's why we do only coding audit at that time. And at the beginning of the year, we based on the national guideline from Ministry of Public Health to follow the medical guideline. Until the 2010, we have our own audit guideline along with the national guideline to do the audit. The percentage of the audit system at that time, we start from only 1% is cover about 100,000 admissions to more than 3% in 2018, cover about 200,000 admissions. All those, in the past 2 decades, we are based on post-audit. We never do pre-audit before. And then we start to do and then in 2019, we have a big issue on fraud and has been on the headline news for many days. From that time, in 2021, we start to do pre-audit system before payment in specific issue that we think it might be suspicious. So in 2021, the number of charge that to do post-audit are less. Is only 50,000 admissions. And in this fiscal year, we expect to launch the AI audit system in parallel with the regular audit system. So let's see how it's going to turn out. Next slide, please. This slide is just give you an example of selection criteria for coding audit. Since we have almost 6 million admissions of inpatient care per year, we cannot do audit every admission. So what we did before is just to select the suspicious admission with the high risk condition. For example, the top 20 disease ranked by the number of admission, or the unrelated procedure with principal diagnosis. So with this type of selection, we found a very high percentage of the abnormal claim. The audit department of the government, another audit department is the big one. They just said, why you have the very high percentage of abnormal claim or something like that. We have to describe, tell them that we selected the high risk one. We not do or randomize for all claim. Next slide, please. And however, when we find the abnormal claim, what we did mostly before, like for overclaim, we just request, we just balancing the financing account between the hospital. If we find the overclaim, we just deduct money from their next statement. If we find the lower claim, we add more money for them. That's all most of the time that we did. We usually do very little on blind misconduct or any other case. And however, not only the claim, we have other benefits from audit that the coder, the coder we use of every hospital in the country also have a chance to have more experience and to enhance their capacity. And the most important one, that accuracy of health information system of the hospital or the health system as a whole will get a great benefit of our audit system. Next slide, please. After we achieve the USC, we still try to continue to develop our health system in order to sustain the USC. However, the effort to develop the USC system also in turn, they have also created more challenges in claim and audit system. For example, we try to give more incentive for care. So that's why we have, from beginning, we only have the capitation and DRG. Later, we introduce more type of payment. For example, the fee for schedule for health promotion, and on top service for high quality of care. Many times, so it create various type of payment, and also to have more fund management. Before that, we only have two types of payment, like for outpatient care, for inpatient care, that's all. But later, we have many types of fund management. We have many, sub-fund, we call sub-fund, for HIV/AIDS, for cancer, for heart disease, for many types of disease. So it's made the claim and reimbursement is more complicated and also difficult for audit. And in the last few years, we have also introduced other type of service. I mean, we used to mainly based on government provider hospital, but later we try to engage private sector in various type of primary care. For example, the drugstore, dentist clinic, to join our service. Most of the time, I mean, normally when Thai people went to hospital, they will get everything from the hospital, include the medicine. We don't have to go to take the medicine. They spend the medicine from drugstore. But because the hospital very congestion, with very crowd, right? So we try, now we introduce many types, and especially after COVID, telemedicine, and patient with very small, very mild symptoms don't have to go to hospital. They can see doctor through telemedicine and go to get medicine from drugstore. And this type of, the interactive activity have also created more difficult for us to audit, and also for become more critical issue. Because usually when patients go to hospital, they will have to follow many formal process to detect who they are or everything. But to go to drugstore, but sometimes the drugstore also in convenience store. You will be very difficult to check the person who get the medicine are actually the real person or something. So this is a very huge challenge for us. Next slide, please. However, with the existing electronic medical record and existing fund transfer, everything that we deal with hospital are electronic. I think we don't have paper claim anymore now. And also the collaboration with other government agencies, both in health and non-health care sector. Some of them can help us with the standard data, and also even developing the platform, the digital platform, for example, for authorization or for authentication before patient get the medicine from drugstore. And these are, many of them we use the other government agency like banking, or like when the patient want to go to the drugstore, they have to authentication themselves through the banking application, government banking application. And then they go to the drugstore. From drugstore, they also have account that can check in the application, see of the same person, and then they dispense the medicine to them. So this have eased our process of claim and audit system. Next slide, please. This slide just show you the easy diagram for all this system that we gonna integrate into our e-claim system this year. I mean this fiscal year. And all this system will be, usually we only do, we call rule-based claim, right? With this type of service, how many claims you can get or with which condition. Since they are all electronic, sometimes in computer, right, you can put any data in. So mostly always be correct. But AI audit system will help to target the suspicious abnormal claim, even they are follow the rules, right? So next slide, please. So this picture will show you our claim system after we integrate the audit system. All claim data after pass the process of verification and validation in e-claim system. Usually just follow to pay money to hospital. But now with this new system, some of the service data will have to go, that require pre-audit, have to go to AI audit system to categorize, and we have 3 colors, right? The green one is for pass, yellow one for warning, it might be suspicious, and the red one are denied. And we will have we call on-screen reviewers. We will have somebody to checking on the screen again that from the result of the AI system, if they agree or not. And then for the yellow one will go through the pre-audit. But like we might request they submitting the chart, patient chart, scanning. They will scan the patient chart and submit to our system. And then we hire the external auditor, which are the doctor, nurse, or coder in hospital to do a checking, to do the audit chart from we can say paper, but it's not electronic in the computer, to see like the order have to be signature of doctor, or the diagnosis have to be relevant with the treatment or something like that. And all the service data that pass the audit will follow to pay as regular. So with this system in the future, post-audit will be less and less, right? This one can save a lot money, because when we have the problem on fraud a few years ago, usually we spend the money for audit maybe less than 1% of the total claim, maybe only 1 or 2%. But when we found fraud, I mean intention that clinic, we have to do 100% of clinic. The audit costs have increased more than 10% of total claim or something like that. Next slide, please. So the section for the future improvement will be, first of all, that very important one is that other laws, for example, the civil laws, criminal laws, or any other related health professional laws that control doctor, nurse, or health personnel in hospital should be compiled in the case of fraud happen. Before that, we also do something that we report to the they call medical association or something, but maybe not very seriously to punish anyone or something. So in the future, we will be more and more law. Sorry. And another thing that is, like I told you, be based on external auditor. Even we have about almost 3,000 of external auditors. Well, nationwide, all of them are work in hospital or retirement one, like doctor or nurse. like for auditor, for the very easy one, like just screening, we may use only nurse or to do the audit. But for the difficult one, like heart surgery or very complicated treatment, we use the specialist, the doctor specialist to treat it. So the cost for audit per case are very different, from a little less than $0.25 up to maybe 20 or 30 US dollar per case. It depends on how difficult of the case. So, and we only have less than 10 people for, our internal audit. So most of the time, our auditor do on the designing a process, like which condition should we do or something, to check what type of service, and also to approve our program for audit. After the audit system have been in condition and the applicant have been approved, the external audit will audit follow our rules. And the other thing are also very important that we already apply something that to use digital platform to help our system, for example, AI system on screen review, and also increase efficiency of the audit system. For example, to authentication have to be required for some type of service before access to the service. And also API system to connect with health information of hospital in order to improve the quality of data and also to reduce human error instead of key in directly between the program to send data to reduce and also to reduce workload of providers. They don't have to repeatedly key in the same data in many systems or something like that. I think that's all for today. Thank you very much.
Thank you very much, Ms. Piang. And I think with your presentation, we have seen the complexity of all persons involved, all the opportunities to perform, to have fraud, and also how many people are behind the scenes. And of course, emerging technologies are important and they help. And like you say, you have a whole evolution that you have showed us and which is very impressive. And we congratulate you on this. But of course, you will not replace human resources. And like you say, you have many external auditors. It is impressive, which brings, of course, other problems of integrity and how you can address this in this very sensitive topics of fraud. And then, of course, I would be very interested also to see how you address errors and abuse and potentially, if we speak about corruption also. Thank you very much for this very interesting presentation. So we will now have the opportunity to have the, let's say, views and experiences from Vietnam and from Malaysia. So I will first invite the distinguished speaker, Mr. Dung Dung Thuc from the Social Security Vietnam, to provide your feedback on the presentations that we heard and to share your country experience on this topic. Thank you very much.
Yes, thank you so much. Thank you so much for the presentation. And good morning, ladies and gentlemen. We have 10 minutes to talk about the presentation. And so that we would like to introduce my team. We work for Vietnam Social Security. I think that some of you come to Vietnam a few days ago. As you know, fraud is a big problem in the world, in every country, and especially in Vietnam, because we only use fee-for-service mechanism. I think that Thailand, we now use fee-for-service fee schedule. That is there are some things the same in Vietnam. Vietnam have a big problem because the payment mechanism because I think that is excellent benefit package. You know that in the case of USC in Thailand, there are three schemes, there are three payment mechanisms: DRG, capitation, fee schedule, and three fund. That is, you combine or separated mechanism so that our system of the NHSO are perfect but so complex. So that I'm special interested in medical care audit based on clinical professional guideline CPG. I have one question, a small question here. Who and who's build and publish CPG? That is very important because if the health insurance agency have that, but the hospital is not agree with us, there are different with us. That you use big data, data mining, and AI to build CPG. Most of machine learning now, we use training from human knowledge. The fraud was identified, same in Thailand, same in Indonesia. But there are many fraud we don't know. How do you think if we use unsupervised methodology to build most of CPG so that we can create electric doctor? We can help the doctor and the patient the right treatment, reduce human error, and reduce workload of provider. And I think that is better than we now cat and mouse. I think that excellent if ESA set up an AI network as the same organization, non-profit organization in Europe. So we can work together, we can share experience, we can do faster and stronger as slogan in BPJS Kesehatan. I think that my friend, my colleagues will have some more questions for you. I want to say thank you so much by Indonesia language. Terima kasih. Thank you. So my friend have some questions. Okay.
Thank you very much, Mr. Tung Tung Duk, for your questions and for sharing your precious experiences. So, is it okay for you? Yes, please. The floor is yours.
I think I get two questions, is correct? And the first one is about the clinical guideline, right? And what we did is we don't develop the clinical guideline by ourselves, we based on the medical professional association in the country. For example, for heart surgery, we use the guideline from they call heart, I don't know, cardiac, right? Cardiac doctor association. Or even before we implement the specific fund, like for HIV/AIDS, we also based on the National AIDS Committee. That committee that include the NGO, Ministry of Public Health, and doctors, specialists in that field. Even the government pharmaceutical organization who manufacture the medicine, and then to how to say, discuss in many issues like the medical standards, the budget. Like sometimes if the medicine is too high, we cannot cover it. They will be postponed. For example, for HIV/AIDS, before 2005, the price of the anti-HIV drug is very high. We cannot, how to say, include in the benefit package. Patients have to pay by themselves with the medicine, right? At that time, the National Committee and also the Ministry of Public Health, the Minister of Public Health that time, they do, I don't know, they call compulsoring, right? Medicine to develop, to manufacture the medicine by ourselves. And even some medicine we import from India. So the price of that will lower a lot. So we can have benefit package in 2005 for everyone. And also for chronic kidney disease, right? And before that, the hemodialysis are very high too. We have to be exception in our benefit package. if you need hemodialysis, it's not covered, you have to pay by themselves. It costs many people bankrupt, right? Bankrupt. And then that's also a few years after the HIV/AIDS, we introduced the peritoneal dialysis to use dialysis through the abdomen. The cost is dropped a lot. We buy we call PD fluid, and join with the government pharmaceutical organization. They send the fluid. At beginning, we don't know that it's that much because most of the time patients get a medicine from hospital, right? But this PD fluid is every month they need to use a truck or bag of fluid bag, maybe 200 bags per month or something. We use postal office that they have special truck to deliver the PD fluid to patient house, directly to patient house. So everything we do, we use the connection and network in our country. Everyone do their job and we support each other. Our office just to pay money, we act as the purchaser and try to manage the system in order to be within our budget because we have very low budget. Even now, the capitation per person per year is only a little more than $100 per year. But we manage for 47 million people. And we can say that now we have very comprehensive benefit package. And your second question is about something like DRG or ICD-10 data, right? This also we use international standard, the ICD-10 from the WHO. But however, Thailand we have national committee also again. It's not our office, we only use the national committee. They will have they call discussion or maybe seminar every year to revise the DRG. DRG is stand for diagnosis related group. And in order to have, from DRG, every admission will be from DRG, from ICD-10 will be in the code like C18 or something from the WHO, along with other data, for example, length of stay and complication, age or something will be calculated to be called related weight score, RW. From this score, we will pay for the inpatient service, not based on the billing, but based on the score. Now, one related weight score, we pay about 8,000 baht per 1 point. So if that visit have 3 points, they get 8,000 by 3. So 8,000 baht is a little less than $300 only. And I think that's all. And also experience, Thailand and Vietnam has been share experience to each other, I think maybe more than a decade already. And also, one other thing that I want to share you too, our fee schedule service, we also learn from Japan. They have a big huge book, right, on fee schedule system. So we try to, because Thailand we have problem that, some of the service and patient cannot access. Maybe our payment is too low, is in capitation is not incentive enough. So we try to pay them by service, right? How many times get in, but the price are based on fee schedule that we set up. Also, this price also set up by the committee, national committee also. So that's why we have less agreement in the payment rate. Thank you. I think I answer your question.
Thank you very much, Ms. Piang. Thank you very much for all the information that you're given. And I will now turn to Mr. Hasnal, who is the head of the Division of Anti-Fraud, Ethics and Integrity from SOCSO, Malaysia. So, Mr. Hasnal.
Hi, very good morning. Thank you, Natalie. Assalamualaikum dan selamat sejahtera. We always say it in Malaysia. I probably just want to share in terms of our challenges in social security in Malaysia, just to complement what was presented earlier. Perhaps I wanted to share as well on SOCSO Pekeso itself. The organization itself was actually is a self-funded organization in Malaysia under the Ministry of Human Resource, and we have approximately total of 3,000 employees, and of course in terms of the employers, I think we have currently actively about 440 over thousands active employers, with 7.1 million active contributors. I mean, that is the employees, and I think at the moment we are paying paid claims cost us about 4-something billion, about $1 billion every year. That's the liability that we have, and we have to look into the revenue leakages from that particular payments, and we have close 700,000 claims. That's the one that we manage. I am actually fortunate enough when I joined Social Security Malaysia, as mentioned I think earlier by Bapak President Director. I myself have experience in insurance. I was with insurance company for almost 15 years, looking into fraud, risk management, compliance, and of course looking into both, mostly I spend time in life insurance than general insurance. And my take is that in terms of frauds, both in insurance sectors and social, in public social security, I think it's almost similar. The only two difference perhaps, in insurance, I think we are looking into term and condition and contract, whereas in Malaysia, we tie our payment or cyber back to our act. We have act which has been there since 1969, and it has not been amended since then. I think that's one of the challenge for Pekeso because of our fund. And at the moment, I think we have total fund close to 10 billion USD. And of course, that is kind of institution that we have. So our focus actually to look into the sustainability of the fund. I think that's the main focus. And of course, in terms of challenges, like I mentioned earlier, I think in terms of fraud in both sectors is almost similar. I was fortunate enough to get involved in study to look into insurance fraud in Malaysia, in Indonesia, in Singapore, because one of the company I used to work with actually a Singapore-based company, and of course I have a chance to work in Brunei for a short period. So I think in terms of fraud at these four countries, I would say that it's almost similar. At the end of the day, we look into people, we look into money, dollar, and cents. I think that's at the end of the day. In terms of challenges, I suppose in Pekeso, one of the main challenges actually in terms of what we offer to the insured person. I think that's kind of things. Once you give this kind of benefits, it will be very difficult for you to pull it back. For example, like we have in Malaysia, like mentioned by the speakers, we have this dialysis services which we offer to our insured person, and it costs us about, I would say that the one this year latest would be close to 100 million US dollar every year. Yeah, that's in terms of the liability. And of course, in terms of challenges, I would say the people that we have, that's why that's the thing that we focus on. I think we have to increase the competency of the staff, yeah, our own staff as well, how we look into things. And of course, in Pakeso itself in KL, we quite well positioned that we have audit, we have risk management, we have compliance, we have my division there. We are looking basically into anti-fraud issue with regard to claims, fraud claim. And we also looking into issue with regard to staff misconduct. And I myself, so I'm looking into the integrity. And of course, we are certified anti-bribery management system. We are certified by that, yeah. And that's something that we need to keep. And of course, the challenge, like I said, another thing challenge, we talk about the system. I think that's very important. As you move forward, I suppose we need to focus on a good system, a good detection system. We coming up with our own system with zero cost. And of course, we covered that as well with our another subsidiary of Pakeso, which is our medical rehabilitation in Malacca, Kuala Lumpur, KL. And then another challenge, I would say that in terms of this is one of the major problem that we have in Pakeso KL, where we have the involvement of NGOs, of the middle persons. These are people who coming to us on pretext that they try to help the insured person to file the claim. Yeah, this is, to some extent, you can say that this is among the people behind involved that, the one that we have to manage, very well. And of course, I would say that in terms of the governing bodies, that is one of the major challenges, because I think in terms of the act that we have, in terms of definition of fraud itself, it has to be complements to the law that we have, yeah, because you have the definition, and that definition should actually in line with the law that you have. If you have variation on that, there will be a problem. And of course, my experience in insurance and with Pakeso now is that, of course, we have several issues where when you have those prosecution cases, then you have officers who actually are not aware, who don't have the knowledge actually of what you have. So that will be the main obstacle, because what we're doing now, we're doing in terms of to look after the revenue leakages. You have to ensure that even when you go to prosecute, you have to win those cases whatsoever. I think toward the end that's very important. And another challenge, I would say that when you have a service delivery, that you promise people you are social security, that you have to do good, you are for the good of the people, and of course you have to close your eyes on some of the process internally. You have to fast enough to pay or something. I think this is one of the major problems as well. And I experienced this as well when I was in insurance company, yeah, where for insurance, you want to pay very fast claim. In fact, you want to pay claim within 3 days. But you have to ignore some of those risks that you have. I think that's happening now. So at the end of the day, this is kind of things that we need to look into, yeah. And in terms of, I think, the strategy that we have, we basically, yes, we capitalizing on data and AI. Yes, of course, artificial intelligence is very important, data, and of course, system and technology. And in fact, we embark on actually using drone to do our civilian team, field officer. We put the drone up there. We have our target, so this is counting that helping us to obtain or to secure the evidence in the event that actually we're going to prosecute any cases, yeah. And of course, we capitalize also on biometric, yeah. But biometrics is some things I would say new to us, but not so new when I was in insurance company. We've been implemented these kind of things years ago. Yeah. In fact, when I joined Social Security Malaysia, to some extent we are a bit late. I would say that we are about 10, 15 years behind the insurance company. But I think thanks God now, I think we are the same par with the insurance company. We have a good liaison with the insurance company in Malaysia. We have meetings regularly to discuss and to share information, kind of thing. Yeah. And anything I want to say? Okay. In terms of what we do, actually, apart from benefit claim, I mean, in social security in Malaysia, I think we also involved in disbursing the government's fund. During the pandemic, I think the Malaysian government, we spent in hiring incentive officers, we spent about 23 plus billion. That is close to almost $5 billion US. And this is kind of data they were looking into day in, day out. And the team basically managed to suspend or to stop payment close to $100 million US. And that is counting. And I think so far, yes, we are quite successful in terms of prosecuting the offenders. One time, I think in July this year, we worked together with the Malaysian Anti-Corruption Agency, which is to Indonesia close like KPK. Yeah, that counting that we're doing. Of course, the thing is that what we have in Malaysia that we have these two enforcement agencies, the Malaysian Police, Malaysian Royal Malaysian Police, or the MSCC, and they have two different acts. So we have to study what is the best way for us to prosecute. Are we going into the act by the Malaysian Anti-Corruption, or we go along with the Malaysian Police? So I think that's what I'm doing. I would say that moving forward, yeah, and the best thing, this is the practice that we used to practice when I was in insurance. I think the best thing is still like you have to protect yourself first. You have to have a strong internal process in your organization. I think prevention is better than cure. I think that's all I can say. Thank you very much.
Thank you very much. And I think with the wise words, prevention is better than detection and redress of healthcare fraud. I think we say a lot, and I hear many things in your intervention, and I thank you. You talk about the system. You also talk about the human resources, of course, about a good system, about the role of the governing body and the regulatory basis to address it. And of course, you have always a difficulty. You want to do better, faster, and you want to pay the claims as fast as possible, but which gives you, of course, less opportunity to control and to do it in a proper way. And once it's paid, it's much more difficult to redress the fraud and reimburse. So I think it's very impressive also all the emerging technologies that are being applied in your country, in Malaysia. And I think you even talked about the drones. So it's really impressive that this all contributes to the discussion and how we can identify and tackle fraud in a better way. But I hear a lot about, let's say, non-compliance to billing rules, of course. But fraud is much more. And fraud is sometimes also considered as being, let's say, overconsumption, underconsumption, unnecessary care, or paying too much for something for which we could have paid less, and which not necessarily enhances the quality of care. So how do you address this broader scope of wasteful spending in healthcare, which is sometimes intentional, where we talk about defining fraud? It could fall under the scope, but it is like a gray zone, and it's not very clear. So how do you address those cases, if I may?
Again, normally we will based on the, first of all, critical guideline, right? I mean, and also the healthcare statistics. For example, how to say, the percentage of people that can have some type of disease or something, and those are is kind of very complicated, right? So from the data, you can see that one slide that I show you example of selection criteria. From the data, since we have a huge data, and we try to also apply big data technology to do this with this data too. From the data, we will see abnormal data. For example, from the slide, the top 20 disease of admission. So normally in Thailand we have a hospital that the district hospital, provincial hospital, and the hospital of the medical school. Each of the hospital, they can do some type of service are different, right? So for example, heart disease, with some type of hospital, they might can do, but they cannot do a lot of case because they don't have a lot of doctor or something like that. The number we show, and they will be pointed to that disease or something. So in order to classify this type of criteria, we not just think by ourselves, we also through committee, which integrate from doctor, from hospital also. And when we do audit, we use external audit, right? Doctor cannot audit their own hospital. They have to audit to another hospital or something like that. And everyone cannot tell they are auditor of our office and cannot say, oh, we audit your hospital, something. No, it's privacy. They have to be high. Even when they audit, they found, oh, this doctor is my friend or something. They also cannot tell their friend that, oh, you do this wrong, you should correct that, correct this, cannot do it, or something like that. And the only thing that we don't have seriously punishment. No, normally we only warning. Like when we found doctor that do, maybe cannot see misconduct, but maybe not appropriate one. We only send a letter to medical, they call medical association, or maybe like that. Let them to how to say, to check and to check behavior of their own doctor or something like that. We don't do that kind of something.
And that's, yes, and that's also related to the conflict of interest, etc.
Yeah, conflict of interest.
Yes, very good. Thank you for bringing in this. Thank you for your information. So I think that at this stage we can open the questions from the floor. I'm waiting for instructions. But in the meanwhile, I can already say that thanks to Professor Gofar Mukti, we are addressing all these topics very intensively with the Technical Commission on Medical Care and Sickness Insurance. And it's a very wide scope. We have been tackling the topic of fraud in healthcare, also through the emerging technologies. We had very interesting webinars, we drafted articles on it, but it goes wider. We also go into the appropriateness of care. For example, where do you draw the line, and where do you really talk about wasting with intention, and how far can we go to really make sure that every dollar and every rupee is used at the best intention and with the best quality of care for the benefit of every patient. So my sincere gratitude to Professor Mukti for all the work that you're doing with us and all the input, and you put a lot on your shoulders, and thank you very much for that. Yes, please.
Hi, ladies and gentlemen. We are from Vietnam Social Security, and according to your presentation and follow Mr. Dương Tuấn Đức comments, I would like to ask, when we code auditing the data from the hospital, what is the percentage of the fails code auditing? And are the hospital able to resend the data for code auditing again? And if possible, how many times they can resend the data? And I have another question from my colleagues also.
Hello, I'm from Vietnam Social Security. Thanks for your presentations, and do you share your experience about criteria to do medical care audits of hospital? And how long does it take to finish pre-authorizations? And do those pre-authorizations make treatment more slowly? What does high-cost drugs and procedures to apply in pre-authorizations in Thailand?
I think I will answer the second one first because it is maybe shorter one. Okay. For pre-authorization, we have do through the application online, and some of pre-authorization we do by doctor in hospital. I mean, in specialist in medical school or something, and it will be very fast, maybe within 1 day or something to approve it. That's it. And for the example of medicine, sorry, I don't have the list of drug, but it's something, for example, for the cancer drug, very high cost drug. Maybe one cost is cost you more than maybe 100,000 baht. It's maybe more than 300,000 US dollar or something like that. And approved by doctor, especially doctor in that field, which not our employee. It's doctor in the field. So it's like let the doctor do manage their network in their network or something like that. Is that okay? And the list of that, sorry, I don't remember all the list of names. It's all very difficult one. But it's mostly for cancer, I think, yes. And also some type of medicine that how say require specific condition, even though it's not high, but it's not safe to use it or something like that. So, for example, doctor in district hospital have to be pre-authorized by doctor from provincial hospital, that's specialist or something like that. It's okay. And for another question about coding audit, like I told you before, the coding audit we selected the high risk one. So mostly when we selected, we almost see it's always wrong. maybe 30-40%, it's very high. But in terms of overall, maybe not that high. But since we are selected, so the percentage is high. What we do, I will take a little more time to explain the e-claim system. When hospitals submit claim data, we have the basic check-up in computer, like with ICD-10, have to be relevant with the code, the project code, like when you claim for CA, the cancer, the ICD-10 have to be related to that, something like that. That is the basic check-up. But however, the name that they call is overcoder. For example, appendicitis, if we do operation or something, the basic one with this code. But for rupture, appendicitis, we use another code, right? And you get paid, higher pay or something like that. This one needs to be audited before you can know it really rupture or not. For the patient chart, you will see like the history or check-up or laboratory test or something related to that patient. And this one audit, we use the doctor to do it too. I think it's answer your question. Thank you.
Thank you very much. And I think that we can see the discussion from different perspectives. We have the country experiences, but we have also, among the participants, other persons who see it from a broader perspective, and more specifically, our colleagues from the World Bank. So may I invite you to give your thoughts on these important topics?
So thanks very much, Natalie. My name is Ajay Tandon, and from the lead economist from the World Bank. So just a very nice, thought-provoking panel discussion. I just wanted to rephrase and perhaps reiterate a point. I mean, there's not a right or wrong answer, but I think the point that Natalie made, that should we be looking at fraud as part of a continuum of provision of low-value care, right? So where fraud is viewed in the same context as also bad quality, or is it something that fraud is treated differently because, you know, there's a criminal intent in fraud, whereas if you're just providing low-value care or low-quality care, there's no criminal intent, even though, you know, in some ways from a health perspective, it's just as bad. The reason I'm saying is that, you know, when in India, when they launched the Ayushman Bharat PMJ program, there was this obsession with fraud, fraud, fraud. And I kept asking the counterparts, I said, why aren't you obsessed with quality, quality, quality? Right? So should we combine the two? This is not just India, it's happened in many other countries where there's the instinct that, oh my God, we are now contracting private providers and we're paying through the demand side. But shouldn't we also be worried about quality with the same energy and the passion as we are worried about fraud? It's just a question to pose for the rest of the day also. The other point is sometimes some of the language that's used, and I think Natalie made a very good point that, you know, we need to understand what is fraud, right? How are we defining fraud? Otherwise, how do we address it? But I've always been confused as to what's the difference between fraud and abuse. Right? Is it the same thing? Why is abuse a different word? I know there's, again, not a right or wrong answer, but why even distinguish between the two? And also, many times, you know, fraud can take different dimensions. And, you know, one of the things perhaps we should think about is not just the amount of money that's going to fraud, right? But also how badly. So we should prioritize fraud that's hurting the health of the people, right? So it may be that it's, you know, we have a tendency to say, oh, so many millions of dollars were lost to fraud. But fraud can also create health problems, right? It can lead to loss of life. And should we not be prioritizing fraud that's harmful for people's health? For instance, you know, overuse of C-section. Sometimes that's not considered fraud, it's considered abuse. But it can be harmful for women's health, right? If they're getting unnecessary C-section rates and things like that. So again, it might be important to bring those contexts. And I think more generally, the point I'm making is not to focus so much on accounting, but on accountability, right? Accounting means you're just looking for making sure the money is being spent correctly and things like that. But accountability is really about saying the resources are not only being used effectively, and perhaps we don't even care whether they're used in the right way, as long as you're getting the end result to the extent that you can allow some flexibility in how the resources are used. So not really a question, but some comments to sort of inform the thought. But please feel free to respond if you want. Thanks.
Thank you very much for your insightful contribution. So do you want to react first, please?
Yes, it's a good mention. I want to maybe add more experience from Thailand. I think the most important thing that we have to very serious about fraud or abuse or thing is that we have limited budget. Right? Instead of use the same budget for people that really need it, we have to pay for patients that don't need it. I will give you example of COVID, right? In the past 3 years, every year we use the budget for COVID almost at the same amount as we use for every disease. Like in my office, we need extra money from the government, especially only for COVID. Use the loan money, and when do audit, we feel very, I don't know how to say it, pity or sorry or something. Supposed to be for screening, for example, ATK testing, supposed to be give to the person who high risk people, not someone who not not high risk, but because the payment we give maybe is too high for unit cost. Car is too incentive. They do so. Some clinic they went to every factory and test everyone in that factory. Especially if I don't know, they use a lot of money, and then we cannot say that they don't give care. They give care, but maybe unnecessary. And we can use that money for people with HIV/AIDS, with cancer, with many other disease or something like that. That is very big issue that we need to be concerned. Yeah, thank you.
Thank you, and I just want to react before we go to the next question, and I thank you very much for bringing in this, because first of all, there is the lexicon of infringements that we talked about already, and especially from EHFCN, and you ask about the definition of abuse, right? So they define error as unjustly obtaining a benefit of any nature by unintentionally breaking a rule. That's the error. And the abuse is unjustly obtaining a benefit by knowingly stretching a rule or taking advantage of the absence of a rule. So that's how they, and then you have of course fraud, which is illegally obtaining a benefit of any nature by intentionally breaking a rule. And then they go further to corruption, saying it's well, by abuse of power, by third-party involvement. So that's how they define, and that's the lexicon of infringements. And then when we talk about wasteful spending, we also have, of course, a very interesting publication of OECD in 2017, tackling wasteful spending on health. And they talk about waste, saying that either patients do not receive the right care, for example, duplication of tests and that things are not necessary. Either the benefits could be obtained with fewer resources, which then, of course, helps for the sustainability of our systems, or either the resources are unnecessarily taken away from patient care. And there they see the administrative waste and also fraud, abuse, and corruption. So this was just for information, and we can now go to the next question. So I think there's a question. Thank you.
Thank you. Good morning. I'm Riri from BPJS Kesehatan. I would like to ask Ms. Piang. You already explained that you have 3 schemes in health insurance and also 4 payment system, such as capitation, the RG, and also fee schedule and on top payment. I think it's a big challenges for you to detecting fraud. I have 2 questions. You already explained about the audit claim. If the result of audit outcomes found and the healthcare should, the offer claim should return to NHSO, beside that punishment, is there any punishment or treatment to prevent that hospital doesn't do the same case? That's the first question. And the second, thank you very much to explain about your claim processing. It's very interesting, and you also use AI verification. Based on your experience, how effective using AA verification to detect the fraud in your NHSO? Thank you.
Thank you. The first question about the punishment for overclaim, right? Like I told you before, that most of the time in the past 20 years, most of the time we only deducted money from their accounting, right? It's because for claim, like Malaysia experience, that one thing that we have to pay faster. One of the things that we do, we call claim statement every 15 days. So after, I mean, the hospital have to submit claim data every day, and we process every day, and then we have statement every 15 days, and we will pay money every month, right? And for audit, when we do coding, do either coding audit or pre-audit, if we see that they are overclaim or there are something wrong. For pre-audit, it don't have request money because we for payment, right? But for coding audit after claim, if we find that, for example, we say, okay, 10 case with this amount of money have overclaim, we deduct this money to next statement that before pay to hospital. And we have very few cases that we report to the upper level, but normally we will have official letter write to the hospital and tell them what is wrong when we file their chart, and then we give suggestion. And also, I told you for the claim audit, the coding audit we do by professional. I mean the doctor, which are they are specialists that sometimes they are teacher of other doctor in that hospital. So it's they kind of have power. They call intensive power to tell that, like with this heart surgery, you should follow this procedure, do this test, that test before surgery or something like that. It's kind of, I don't know, they call soft power maybe. It's not real punishment. Because lifetime, I think most of the time we just see it as abuse, right? Hospital just put more coding to get more pay. And also one other thing that most of them, almost all of them are government hospital. And then however, like I told you that a few years ago we have big issue on fraud, but that not in hospital, in small clinic they do screening, like they do screening for for NCD, right, for DM or hypertension. First of criteria that patient, that person have to be high risk. For example, they have obesity, they have parent with DM or something. What the clinic do at the chain data to make the patient have high BMI. For example, the last time their body weight is 50, they change to maybe 70 or to get higher BMI in order to meet criteria for NCD screening. In that case, it's because it's very obvious that's false. So that's why we have a big case. We call DSI, I don't know, it's especially the doctor, the police involved into the case. And we also file the case to the court. So, and now maybe hundreds of cases in court with that many small clinics. That intentional. But most of the time we see it as just abuse, just to get more money for their care or something like that. Is that okay? Is answer your question? Thank you.
Sometimes it's very easy to see that it's fraud, isn't it? So, you had a question also?
Yeah, I would like to just add to Ajay's point. I think quality is very important, and there's no doubt that we are just looking at fraud from more of an accounting purpose, because that's probably more objective. When it comes to quality, I would like to add that quality could be in the terms of medical outcomes. So I think where there the domain of negligence, criminal negligence, probably that kicks in. An aspect of quality could be patient experience and the overall quality of care. I think there the market forces would kick in the private sector. And I think both these aspects of quality would be, need to be taken care of by empowering the patient, the citizen, by informing him that just because the government is paying for it, he has to still demand the best of the services. So in case he feels that he has been short-charged, he should be, he should take action against the hospitals who are indulging in providing poor quality care of whichever kind. Accounting is, of course, more easier to see. It is above the surface. And there, I think Natalie has already clarified regarding the difference between abuse and actual fraud. So it's actually not in buckets. It's a continuum. It's a spectrum. So you really don't know where the mens rea starts, where the intention starts, and where it ends. So it's not a question. It's just a perspective. Thank you.
In terms of, the empower the patient, right? What we do from beginning of USC, that every year we have, the survey from patient to give the score on satisfaction to the UC scheme. And the score are very high, 90% or something like that. But however, in terms of care, is for patient or for consumer, it's very difficult to see which are the quality, good quality. Sometimes they just think, oh, pay more money better. So we have problem that too. For example, for have artificial knee surgery, right? Some hospitals, they do, okay, if you follow the benefit package without pay anything, you might get not good quality enough, but you need, if you pay extra money, you get a better one or something like that. And this is a big issue in our country too, that hospital cannot ask money from patient, and if the patient complain to, we have a department to protect, we call consumer protection department, to solve this kind of case. And many times we get money back to the patient. And now patients are all know, even for example in COVID, recently, COVID, when we have COVID outbreak, right? It's very difficult to find bed in hospital. Even you have benefit package, you have the right to get to the hospital. Many of private hospitals will say, we don't have bed. So you need to stay home or something. But they will ask, behind the scene, if you pay extra money, maybe 200, even as high as 500,000 US, not US, 500,000 baht. How many is very high? It's $500,000 baht. You can get a bed for COVID, and because during the outbreak it's very scary, right? You see people die at home, and so pay. And there are many cases with this one that they pay money to hospital to complain to our office, and then the consumer protection department, we deal with this case and we ask money back from patient. And later many hospitals are scared to do that. At beginning they even don't care to, they give the bill to patient. Later if they want to do, they will say, they will ask patient to pay money, under the table, no receipt, because with receipt you can get money back. So there are many cases that we can get money. So now I think most of patients now know their right, that they don't have to pay money to get a good care. Yes.
Yes, and I think that we almost have to close this panel discussion, but it's true that the COVID-19 pandemic has impacted healthcare delivery significantly, and of course has also potential vulnerabilities of fraud and waste. So I think that we have received much information, very rich, and I thank you very much also for the interaction. I think we set the scene for the further panel discussions, and I sincerely want to thank Mr. Lorenzo Lantari from France, Ms. Piang from Thailand, Mr. Dong Tung Duc from Vietnam, and Mr. Hasnal from Malaysia. So sincere gratitude to all of you. Thank you.
Thank you.
Distinguished guests, ladies and gentlemen, that is the end of the first panel session. Can once again we have round of big applause for our speakers and moderator for such a insightful discussion this morning. Thank you. Ladies and gentlemen, before we continue to our second panel discussion this morning, please allow us to invite you to enjoy the coffee break that already provided at the foyer area of this ballroom. So we will have 5 minutes of break. We would like to invite everyone to have a coffee and snacks and enjoy the coffee break. Thank you. Excellencies, distinguished guests, ladies and gentlemen, welcome back after the coffee break. We hope that you got more energy and focus to continue for our second panel discussion this afternoon. Our next agenda is the second panel discussion, ladies and gentlemen. We'll be discussing the matters on tackling fraud and eliminate waste based on machine learning and artificial intelligence. Our second panel discussion will be led by our distinguished moderator. He is Deputy Director for Data and Information Management. Ladies and gentlemen, please welcome Mr. Doni Hendrawan.
Good morning, ladies and gentlemen, our honorable guests from ISA and our partner countries, and also our honorable President Director, Professor Ali Gufran Mukti, and then our Directors of Supervision, Inspection, and Interinstitutional Relation, Pak Mudiharno, and also our Director of Health Services, Ibu Lili Krisnawati, and all the audience that attending this discussion. Welcome to the second session of the International Seminar 2020 on Fraud in Social Health Insurance, Prevention, Detection, and Elimination. And in this session, we will discuss about the use of AI in tackling fraud and eliminate waste. As we already know, today AI has been extensively used in health insurance, and if I'm not mistaken, there are a few goals that connected with the use of AI in health insurance. The first goal is that we use AI to improve business process automation. The second is that AI is used to increase customer experience, and the last goal is AI is distinguished speaker that will give us a clear and deeper perspective of this issue. So let me introduce these three speakers. The first speakers will be Mr. Tom Verdonk, the President Director of European Healthcare Fraud and Corruption Network. I think Mr. Tom Verdonk is joining us virtually. Is it already connect with? Okay. Good morning, Tom.
Good morning, everybody.
Okay. Can you hear my voice clearly?
Perfect.
Okay. Thank you, Tom. Thank you, Tom. Sorry to make you wake up so early. I think because right now in Brussels it's still early in the morning. I think, is it?
It's 5 o'clock in the morning here.
Oh yeah. Sorry. I hope it doesn't. We not interrupt your good sleep. And the second speaker will be Miss Soing Ming, an Associate Research Fellow of the International Connection Department from Haira, Republic of Korea. Good morning, Mrs. Siu Ming. Can you hear me? Are we connected with Mrs. Siu Ming or not?
Can you hear me?
Oh. I'm looking for Mrs. Yuming, but actually he was behind me. Okay. Yeah. How are you, Mrs. Yuming? Are you fine? Okay, sorry, and again, sorry for interrupting your lunch, I think, because right now, I think in Korea it's already lunchtime. And the last but not least is our beloved Ms. Lili Krisnawati, our Director of Health Services. Please, Ibu Lili, take us place over here. How are you, Bu? Good morning, Bu. So, in Indonesia, we call Mrs. with Ibu. So it means that we really harness the person. So it is Bu Lili. So without further ado, let's start with our first speaker, Mr. Tom Fedong. Have a big applause first for Mr. Tom Fedong. Okay, thank you very much. So Tom, you have 15-minute time to present your presentation. Please, Tom, the time is yours.
Thank you very much. Thank you for inviting me here. I understood that my colleagues from Indonesia will project my slides or do it by myself. No, there they are. Okay, thank you for having me here in this conference. And already congratulations to the organizers of this conference. First, next slide, please. The first slides will be a quick one. So just in a few words, the HFCN is an international non-profit making organization. We were founded in 2005. And for the moment, we have 22 members from 15 European countries. So I will locate it in Brussels in Belgium. Next slide, please. So our aim is to improve European healthcare systems by reducing losses to fraud, waste, and corruption for the benefit of every patient. Next one. So what do? We are a network, so we try to share information and to connect every of our members to each other. We're also tackling fraud and corruption and waste, and we're also on the domains of prevention, detection, investigation, and repression. Next one, please. So I already explained that a bit. So we promote the development of common working standards through education and events, and we represent, of course, our member organizations towards national and international organizations. Next one. So we have some events, we have international conferences, we have small conferences, we call that open houses. We have monthly webinars, we organize ID-tons, and we are sharing good practices. Next one. So, and we also, just in a few words, we also have an AI working group from our members. Next one. So, more on general way. What are the objectives of a solid healthcare system? It has to be sustainable, financial sustainable. It has to be accessible on financial way or administrative way for all the citizens of a country, and the quality has to be good. In Belgium and in Europe, we've often worked with the objectives of quintuple aim, which I will explain another time. Next one, please. So if we look to those three cornerstones of a healthcare system, about the sustainability, there we can talk about fraud and corruption. If we talk about waste, it's more on the quality domain that we consider it has to be taken some actions. Next one, please. So, of course, here are we now together for talking about artificial intelligence. Here we see the health insurance records. It shows very well the large amount of data who are in healthcare available if you have, of course, a good digital system. Next one. So artificial intelligence, we consider it as the holy grail. There you see on the right some types of artificial intelligence, and you see in the middle of it the holy grail. We use it, like already mentioned in the introduction, for different reasons, and we'll come back later to that. Next one. So here you see some differences. What can a fraud analyst do with his limits and with his more positive things? You see it on the back, and what our machine learning can do, also with some benefits, but also with some problems, with some things a machine can't do. It has to be trained all the time, for example. Next one. So typical for Europe is that there is a specific legislation. I'll come back soon to that. So of course, healthcare organizations have an important amount of data, should be used for common good and should be used in a responsible way. And that's why the European Commission has a legal framework for this. Next one. So that's mentioned here. I have to take my slides now because the quality is not 100%. Just give me a moment. Yes, so we have a draft regulation where there will be a risk categorization of AI systems. We also have the GDPR in Belgium, in Europe, of course. The GDPR is the General Data Protection Regulation. Next one. Yes, like you here, we see there was also a public consultation that has been done in European Union, and the deadline is already reached and still working on that recommendation. Next one. There are some main key issues. Next one. Yes. One of the specific things here in that regulation that there is a risk categorization of AI systems. There is 4 categories: unacceptable risk, high risk, limited risk, and minimal risk. So the idea is here to categorize all those AI systems in Europe, not only healthcare, of course, and unacceptable risk AI systems, there will be banned for use. And so you can go lower, and minimal risk, there everything is okay, of course. If you want more specific information about this EU regulation, I can always deliver that on a later moment. Next one. So there will be also the creation of a European Artificial Intelligence Board, who will also work on regulatory sandboxes, a kind of pilot projects to facilitate responsible innovation. Next one. Yes, I thought it would be a good idea to present to you not also some theoretical aspects, but also 2 practical cases from 2 countries who are using AI in a different way, one on the detection of fraud and one more on the prevention side during the billing. Next slide, please. So we have from our Greek member here an example. So next one from Greece. Yes, so they have been working on a case about specifically medical devices and sanitary materials. So there you see for the rest how the rules are made in Greece, and there it is discovered that there are, despite of the current control mechanisms, certain categories present a corruption behavior. Next one. So EUP is the responsible organization of Greece, and so here you see a bit of their data. So it's a data 5 terabytes, and every month they receive 140 gigabytes of new information about those materials. So you see there we're focusing on 3 categories: diabetes management, catheters and medical pads, and special nutrition. Next one. There you see, and I think that's an important thing, and those who are working with AI already know that they did not just use one type, but they used here 3 well-known outlier detection algorithms for selection of the positive cases suspicion to fraud. If you see the next slide, you see here, maybe it's a little bit small, but you see the red dots. That are the outliers detected just by one of the algorithms. And the yellow dots, you see there the outliers who are detected by the 3 different algorithms used here in this case. So that this reduces, if you use multiple AI systems, that reduces your false positives, like we say, the results are coming off suspicious to fraud, but after examination doesn't lead to anything. Next one, please. So very interesting also, and I think it's useful to mention here, is that there also, you have a juridical part of it, because there in Greece here, the Administrative Act was challenged in court, and the providers of those materials, their arguments were that an algorithm cannot provide safe results and cannot replace the person control of bills. So the idea of IA was here bring to court. Next one. So, but the court here, you can read it there also, agreed with the use of the algorithms, and the argument was that the chosen method ensures, on the one hand, the random selection of the sample, on the other hand, the application of theoretical theory and probabilities to evaluate the result of sampling and its reduction to the total cost which healthcare provider. So here the court followed EOP in the use of AI, and now they have a legally base for using it, and I think that's an important thing. Not only using AI on the technical side, but also you have to do something in your legislation to use it with a good purpose. Next one. So another case from Belgium, here more on the billing side, more the prevention side. Next one. Can I have the next slide? Yes. Oh, next slide, please. Do you still hear me? Can I have the next slide, please? I'm not seeing the next one.
Oh, is it the last slide, or is there any other slide? Tom?
There are, yes, there are other slides.
Oh, there are more slides, but oh, okay, but the committees only got this at the end. So can you just continue with just tell the narrative or something like that?
Shall I present or I just talk?
Yeah, maybe you can just continue to talk, Tom.
Yes.
Because this is the last slide that we have right now.
Strange. Sorry for the inconvenience.
Yeah.
Okay. Okay. So I will provide you the slides, but normally I sent you the right one. And yesterday is still an update, but no problem. So here we have a case in Belgium of paper billing. We have a strong digitalization in Belgium, but still a lot of paper billings are introduced. 80,000 handwritten certificates a day. And the sickness funds of Belgium, who are treating all those billings, have a combination, and it's a pity I can't show you that, of different AI systems used to treat all those paper billings. So they use optical character recognition, neural networks, prediction systems, and so they come to a combination of 8 AI applications to do the automatic billing on this system. So in the presentation that I will provide to you, there are some real concrete examples shown, so I will give it to you. Some conclusions. So AI models must be retrained when the model is applied to data. So feedback data is essential for this process, and the goal of feedback is improving the existing AI models. Some other conclusions, I think, for AI now, finally we come from theory to more practical cases that really used, not only in the detection of fraud, but also in prevention, like mentioned here in the case of Belgium. Of course, there's a strong link with the digitalization of the healthcare systems in every country. Important is the retraining and feedback, so there's a machine learning system. Always you have to look for your model accuracy, and I think for at the end a solid regulatory and political framework with a strong will to combat fraud, waste and corruption is still needed besides of the use of AI systems. Thank you very much.
Okay, thank you, Tom, for your interesting presentation. Have a big applause for Tom.
Thank you.
Okay, thank you, Tom. And sorry for the disruption.
No problem. We can deliver the slides later on.
Okay, thank you. And then we're going to move to the second speakers is Ms. Xiu Ming, the Associate Research Fellow of the International Connection Department from HIRA, Republic of Korea. So are you ready, Mr. Xiu Ming? Okay, please, the time is yours. You have 15 minutes to present your presentation.
Okay, everybody hear me?
Yeah, okay, we hear you clear and loud. Okay, thank you.
Okay. Okay, thank you for having me today. I am Sung Yu from HIRA. I'll talk about on-site investigation and fraud detection system of HIRA in the Republic of Korea for this session. Oh. Can I see the slide? Oh, okay, got the chat. And next, I'll start with a overview of on-site investigation first, and next, in addition to the claims review and HIRA office, we also conduct on-site investigation to prevent fake and fraud claims as a supplement and expansion of claims review. So on-site investigation and following measures such as administrative disposition and criminal prosecution are based on a National Health Insurance Act of Korea. Next. So Ministry of Health and Welfare has a legal right to conduct on-site investigation and is the subject of conducting on-site investigation in Korea. And next, HIRA plans the execution of on-site investigative plan and supports all aspects of on-site investigation, such as selection of target providers, conduct investigations, settlement reviews, and administrative disposition. And NHIS also support the investigation for eligibility management, health professional, and post-management of insurance benefits. Next slide. And I'll explain the selection of target providers for on-site investigation and fraud detection system in Korea. And next, to conduct an on-site investigation, fraud is recognized by Ministry, HIRA, NHIS, and other organizations. If the minister requests a on-site investigation for such a provider, the selection deliberation committee will select the subject for a subject of the on-site investigation. And when the investigation is completed, the details of fraud claim will be reviewed again. And when the review is completed, the unfair amount will be counted and administrative disposition will be notified in advance to the providers for penalty. Next slide. When providers are known or suspected of fraud claims, the investigation requests for the providers is sent to the Ministry of Health and Welfare in Korea. And in the process of recognizing fraud claims, HIRA may request on-site investigation of providers with a high probability of fraud claims in the process of claims review, quality assessment, and doing any follow-up management of insurance benefit provision. And it's possible to request on-site investigation of providers that are suspected to have a high probability of fraud claims due to failure to submit data more than twice or by public complaints. And NHIS and other organizations may request an on-site investigation to the minister through additional review of providers with high probability of false or fraud claims. Next slide. The following diagram shows the fraud claim detection system of HIRA. HERA has been operating the system for a long time, so it detects providers with a high probability of fraud claims by analyzing claim patterns for each service provider after accumulating information from other institutions and data managed inside HERA for a long time, and details of medical expenses claimed by the provider, and status report data such as manpower, facilities, equipment, and types of fraud claims confirmed through on-site investigation. So with such system in HERA, organizations with a high probability of fraud claims are eventually selected as subject for on-site investigations, and the actual investigation is conducted as follows. Next slide. So HERA first introduced the system in 2004, while data mining technique was operated with just 5 models centered on the clinic level at the time. But in 2011, it was newly introduced as a current scenario technique and expanded to the hospital level. And in 2015, we gradually added and expanded the types of fraud claims and roles and expanded the systems to the pharmacy level. And in 2018, we began to apply statistical techniques to extracting institutions with a high probability of fraud claims through secondary advancement. The mentioned scenario technique is to estimate the development process of each scenario by imagining various scenarios that may appear in the future. And the rule I'm talking about here refers to the type of fraud claim detection that standardize the experience of the on-site investigators and parent of unfair cases. Next slide. So this is the architecture or diagram of the fraud claim detection system. The database of HERA contains internal and external information, such as claims data, manpower, facility, equipment details, and residence information system, residence information, and immigration information from another ministry, and health checkup from NHIS. So by accumulating this data into a single database, we create a separate mart for fraud claims and divide the data mart for each fraud claim rule to easily search for this data on the rule screen. The separate rule item data mart was created to shorten the time to extract each fraud claim type and to monitor those details in real time. So to monitor this information, it's visualized and displayed on the screen. Next slide. So first of all, the HERA utilizes the information on the supply status of drug and health resources, the bed utilization rate, status of medical personnel, and status of equipment and facilities, and etc. And as for external information outside of HERA, you can use the residence information, immigration from another ministry. This information is very useful to distinguish the types of false claims. For example, if you just use the immigration information from Ministry of Justice to collect and conduct on-site investigations on providers that are receiving medical expenses continuously during the period of departure of a specific physician, you may find out that such institutions have a high degree of false claims, and the hit rate for fraud claims is also known to be high. Next slide. So we also develop fraud claims rules, selects targets, conducts on-site investigation, review and updates the analysis results, and maintains quality so that they can be applied at all times. Next slide, please. So this is a role extraction screen of the fraud claim detection system. For each fraud claim role, the provider suspected of fraud claims and the providers with high risk scores are extracted, and the information on specific detail rules can be checked for institutions with high risk. Based on such So based on such detailed rules, the screen is configured so that even the specification unit can be checked on single screen of HERA to see which specifications are highly likely to be unfair. Next slide, please. So the monitoring screen of fraud claim detection system shows the current status with various point of view, such as by region, size of provider, role, detective fraud, or detective fraud cases by each type of claims. Next slide, please. So this screen shows the status of rule detection by region. The map over here shows the current status of roles detected for last 3 years by city and province. And the graph over here shows the number of providers where fraud claims are being detected by type. Next slide, please. And the following presentation will be about conducting on-site investigation at HERA. Next. So this shows the procedure. The on-site investigation is notified 7 days in advance to providers before the investigation begins. And currently, in principle, all target providers should be notified in advance, but those who are suspected to achieve the purpose of administrative investigation due to the destruction of evidence are also excluded from the list of prior notifications. So during the investigation on site, status check of each employee, investigation order to the representative of the provider, and notification of the details of the investigation are provided. Next. And the actual field survey is conducted to check relevant documents and claims, ask questions to the healthcare providers, check the previously reported data such as personnel, equipment, and facility, and check beneficiaries who are actually provided with the services if required. And according to the National Health Insurance Law, the document should be kept for 5 years. And these materials upon submission are compared with the details of the contract from the healthcare providers. And however, if the healthcare providers violates the data submission order, makes a false report or refuses to be investigated, it can be fined up to 1 year of business suspension or about penalty. Next. And if a illegal claim is confirmed after conducting an on-site investigation, the representative of the healthcare providers and the person who performed the act will be asked to fill out a statement acknowledging certain facts. And upon receipt of the letter, the investigation is now completed. Next. And for the last part, I'll talk about follow management after conducting the on-site investigation at HERA. And as a result of the on-site investigation, administrative measures are applied to corresponding providers. And first of all, the providers that identify fraud claims in the Health Insurance Act will recover the confirmed unfair payment. In addition, the days of business suspension are calculated according to the ratio of the amount of unreasonable profits recovered and the average monthly unreasonable amount. And the disposition of business suspension is also issued. For providers unable to receive a business suspension, the disposition rule may be replaced with fines, and physician's license will be also suspended if necessary. Next. And the criminal prosecution may apply to following conditions. First, when insurance benefits were provided during the suspension period. Second, if documents are not submitted during the on-site investigation process, or if there are any false reports, refusal, obstruction, or avoidance of the investigation. And third, provide with a fraud amount of more than specific amount of those with 10% of fraud claim rate as a result of on-site investigation. And next. And the list of providers known to be have a fraud will be also made to public for 6 months by the ministry, HERA, and the local governments for the public. Next. And this is the end of my talk. Thank you for listening.
We have 50 minutes to present your presentation.
Thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Shalom, salam sejahtera untuk kita semua. Namo Buddhaya, Om Swastiastu, salam kebajikan, salam sehat. Good afternoon. The Honorable Secretary General of International Social Security Association, Mr. Marcelo Abi Ramia Cetano, the Honorable President Director of BPJS Kesehatan, Profesor Ali Gufron Mukti, the Honorable Director of Supervision, Inspection and Interinstitutional Relation of BPJS Kesehatan, Dr. Mundi Harno, all distinguished speakers, moderator, and all participants that I cannot mention one by one. Thank you for the opportunity given for me to present this presentation about tackling fraud and eliminate waste based on machine learning and artificial intelligence. As you may see, I'm not from the IT background, so I try to make it in the perspective of the verification systems. Slide. Before going to the AI, I would like to present, maybe this already mentioned before by Prof. Ali Gufron, but I would like to remind more that membership coverage of JKN program as per December 2022 is around 248 plus million people, which consists of 90.75% of all total population in Indonesia. And we already have a contract with 23,000 plus primary healthcare and more than 2,800 secondary and tertiary healthcare facilities. As the spending of healthcare proportion, now the existing is still more on the secondary and tertiary healthcare services, about 83%, and only 17% of it is spent on primary healthcare. The proportion cost for catastrophic diseases continues to increase, and now it is around 25 to 31% of total cost of healthcare spending that we spend. As the utilization of health facilities in 2000 up until 2021 is around 392.8 million. So it means we have 1.08 million utilization per calendar days in up to 2021. So this is a very huge transactions going over in BPJS Kesehatan. Next slide. So this is the JKN digital ecosystem. As I mentioned before, we have a very huge transactions and involved so many stakeholders. So digital ecosystem is an integration information system is a must. As I have mentioned, we have so many members, more than 248 million people as a members, and we have more than 25,000 healthcare facilities that in contract with us, and we also to our primary care, we have built this primary care application that is also supporting the government vaccination program during the COVID time. We call it PCare, primary care application. As for secondary and tertiary health facility, we have this virtual claim application. And for what we call to ease the payment system of BPJS Kesehatan, we also have more than 650,000 payment channels, including banks, retail stores, post office, online shops, and so on. And we also have to do the integration system with approximately 243,000 business entities that registered in BPJS Kesehatan. So in every day, every calendar day, we have this more than 1 million transactions for healthcare delivery all over Indonesia. So this is why the digital ecosystem is very important and still continues to be developed in the future. Next slide. Now about fraud and waste. Maybe this is already mentioned by other speakers also, but I would like to say something about the Ministry of, we have Ministry of Health Regulation number 16, 2019, concerning fraud prevention in the National Health Insurance Program. In that regulation, there are 5 parties that could commit fraud, which is the number 1 is the members of the program. Second is BPJS Kesehatan as the payer. The third is the healthcare providers. The fourth is drug and health device providers. And the fifth is other stakeholders that is in the ecosystems of JKN. And in this regulation, it is mandated that BPJS Kesehatan, health districts, and healthcare providers have to build fraud prevention system, including to build the culture of fraud prevention, and also to set up the quality control and cost containment team, which is included association of health facilities, also the academician, the medical committee of the hospitals, and also from professional organization that makes the they make a team of quality control and cost containment. So they have, each institution has to build their own fraud prevention team. Next slide. This is the artificial intelligence that we are now still developing in BPJS Kesehatan. As mandated by the Ministry of Health Regulation, BPJS Kesehatan now develops a system using machine learning and artificial intelligence in utilization and claim review to enhance the fraud prevention system. There are three common focuses for AI solution, which are user experience, insight and predictions, and also process improvement. For user experience, we use AI methods including NLP language, specialized device, and other software to improve user experiences. For example, we do smart search with OCR to identify an image in data or PDF file that has been stored in the application via smart search feature. As every health facility who submitted claim, they have to submit several documents in PDF files to be verified by BPJS Kesehatan. The second, for insight and prediction, we use deep neural networks and predictive analytics, as well as established analytic methods to identify patterns, trends, and clusters. For examples, we do OCR module to read the medical documents supporting the claim and match them with the valid verification rules. The verification process is accelerated automatically by AI engine without need for documents to be read by the verification officer for each document attached. So it can be accelerating the time for doing this verification process. We also now is still developing the automated verification for maternity claims. That is actually an assignment from the Ministry of Health for BPJS Kesehatan to do the verification for them to pay the maternity claims. In this Jampersal, the hospital claims is read by the medical document is read it by automatical verification and match with the valid verification rules that is set up by the Ministry of Health. And the third is process improvement. Process improvement uses a broad range of AI methods to improve automation and process flows. For example, detection for unusual behavior, referrals from primary healthcare to hospital-based on some criteria such as recurrent referrals, because some hospitals do fragmentation as a referral visit for certain patients. So we try to detect this kind behavior of the referral, recurrent referral within the last 30 days or within the last 24 hours period or at the same at the same day or the same date. And also we can see for the current year and the current month. And also we do for fraud detection, we get the recommendation for possibility or suspected claim fraud based on certain criteria and claims history for a further analysis. So this AI and machine learning is help us to detect some potential of fraud, and then we go further investigation for that. Next slide. BPJS Kesehatan conduct the fraud prevention through information system in three areas. First is prospective, before the claim submitted. The concurrent is when the claim is reviewed before payment, and the retrospective area is when the claim has already paid for healthcare providers. In a prospective area, we conducted through online referral systems from the primary to secondary and tertiary healthcare providers. So we don't do it manually anymore. So the patient do not have to bring the referral letter. We do it through the application from PCare to the fee claim. So in that case, we prevent this fraud potential. And then we do the membership eligibility validation using the fingerprints in each hospital for certain clinics, and also we expand this for every clinic now. And the third is using electronic membership eligibility paper. So as I said, the patient do not have to bring a referral letter anymore. And the last is we do the rules validation in the application submission. So the hospital, when they submit the claims, they know certain rules that they cannot complete it, so they have to revise the claim before resubmit it again to the BPJS Kesehatan. And in the concurrent area, we are now still developing a system using machine learning that will filter anomaly data, and it will be enhanced into form of artificial intelligence using varied methods such as OCR and rules-based and behavior AI. And in retrospective area, fraud prevention is encouraged from routine activities by doing post-audit claims reviews and also administration audits. In BPJS Kesehatan now is only have authorities to do or to conduct the administrative audit claim only. So we cannot go further for medical claim audit right now. So we don't have full access to the medical records, so we have to do it from the submission papers that is given to us, and we do certain investigation later on with the team that is built in the institution, like quality control and cost containment, as I mentioned before. Slide. In a VD or virtual digital verification digital, we use the concept AI with the OCR modules for checking uploaded files, whether the uploaded documents have been correct or not. If it is not correct, then the hospital have to revise it to resubmit it again to BPJS Kesehatan. And we also use OCR module for reading medical data to match it with certain specific diagnosis, such as, for example, for pneumonia, the AI will read radiologic results and medical resume for clinical signs, and also for anemia, it will read the claim files within the laboratory result of hemoglobin and so on. And the second is rule-based AI. Rule-based AI is, we do it to replace the rules and filtration that is already now in the current application of VD. And then we go to, we doing sampling output results that is arranged in identification number rather than rules category that is exists in the current application. We exchange it with AI. And then the third is we added consisting rules of logic and filtration through the findings that we are now still having. So this AI and machine learning is going through developing still developing for the future. And the third is for behavior AI. We make this certain kind of detection to look up the doctor's, patient, or health provider's behavior. Next slide. This is the last slide. Still, we have certain issues or challenge in the developing of machine learning and AI in BPJS Kesehatan. The first is how to improve awareness of other stakeholders to prevent the fraud in NHI program. The second is to create a fraud prevention culture in National Health Insurance Program. The third is to enhance IT capacity in machine learning and artificial intelligence as a tool to prevent the fraud. The fourth is improving the staff capability to detect and prevent fraud. And the last is enhancing health information system and data management. So we are still working on for this new technique that we do to improve our verification system. I think that will be all. Thank you for attention. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Bu Lili. Again, give a big applause to Ibu Lili. Yeah. Thank you. So that is the presentation from all three speakers that I think all of them are mentioning a very interesting issue about how to combating fraud, especially how to build an anti-fraud systems in health insurance. So I will gonna start a question time. So I will give opportunity to the floor to raise a question. And please, if you want to deliver a question, please mention your names and where you come from and whose speaker did you address. Please, for the floor, you can ask the question. Is there any? Is there any question? Oh yeah, on the back.
Okay, thank you, Mr. Doni. My question goes to Mr. Tom. As mentioned by Mr. Tom, AI is used for detection and, oh, pardon me, my name is Sofia. I am from BPJS Kesehatan. I would like to ask Mr. Tom, as mentioned by Mr. Tom, AI is used for detection and selection of positive cases, and it would be better if we use double AI method. What I would to ask is, we still need people to review AI results or not? And furthermore, how effective is AI in fraud prevention? Is there any indicators to measure the effectiveness of AI? That's all. Thank you, Mr. Doni.
Okay, thank you, Ms. Sophie. Is there any other question, or we'll let Tom answer the question first? Can you hear the question, Tom? I think you're still mute. I think you're still mute.
Okay, I'm sorry. Yes,
okay,
I understood the question. But if I understood right, the first question was, if there is a positive result coming out from an AI system, can it be refused? I understood. Can it be... the second part I understand. Are there indicators of the AI systems when it's effective or not? But the first part of the question was not so clear for me.
Yeah, actually, what Mrs. Sophie asked you is he asked you, we still need people to review AI, or maybe AI can be a standalone?
Yeah,
so
okay,
that's
okay.
The question. Okay, yeah.
Okay, thank you. Of course, the AI cannot stand alone. So if you different AI systems, and there are cases coming up suspicious to fraud, of course, there's always an investigation needed, and there is always a procedure for the healthcare provider or the people who are investigated to prove the contrary, of course. So an AI system can deliver you cases, can deliver you files to check, but of course you never have 100% match that it's clearly fraud. And of course there is always a procedure towards the healthcare worker where they can prove the opposites. That's just a legal aspect. I think that can be different in the countries, but the general principle is of course that every person can prove that they are not committing a fraud. So the goal is here to come as close to the 100% match. That's why we use in a lot of countries different AI systems to reduce the, let's say, false positives. And there's the cases coming up as fraud, but after investigation leads to nothing. And that comes so immediately to the second question. I can provide you something, but of course there are some indicators possible to see if the AI systems are working good. And I think the number of false positives or true positives is an important one. But I can deliver to you if you want. I don't have these here now in this presentation. But for example, for the Belgian cases, there are accuracy figures used, indicators to see if the system is good working or not. But of course, there are indicators possible. Yes.
Okay, thank you, Tom. Do you get the answer, Mrs. Sophie? Okay, thank you.
And I can
Is there any-
provide further information, of course.
Okay, thank you. Is there any other question from the floor, please? Oh, Pak Mudi. Please, Pak.
Thank you, Pak Doni. Thank you, Bu Lily, Mr. Tom, and Ms. Xiongmi. I have a question for Ms. Xiongmi. I'm interested in your presentation related to on-site investigation. My question is, who conduct the investigation activities? I mean, HIRA staff or other personnel from law office. Do you have HIRA? I mean, does HIRA have investigator to conduct the on-site investigation? And how many investigator have by HIRA? And that's the first question. Do you hear me, Xiongmi?
Mrs. Xiuming, can you hear the question from Pak Mudi? I think she's walking or something and lost the connection.
Yeah, yes. Because in BPJS Kesehatan doesn't have investigator. So we need to learn more about the investigation activity that conducted by the other institution. I think it's very important for us to learn more about that. Maybe Tom Farrak can also answer about the investigation activity that conducted by the other institution in Europe to investigate the fraud in healthcare. Thank you.
Yeah, thank you, Pak Mundi. Yeah, Tom, maybe while still waiting for Ms. Xiuming, can you just give a perspective to what Pak Mundi
Yes,
asked a question?
I think you have two parts. Just you need for AI, we call it whiskets, who are on the IT side very strong. But of course, the most of the European countries have a specific inspection service where they can go to the field and they have specific competences and they are all described by law. What can they do? Can they enter at homes? Can they do audition towards healthcare workers? So it has to be clearly defined in your legislation. And in the most countries, and Belgium, for example, there is a specific group of employees of the Belgian healthcare system who has that specific competence based on that specific legislation to go towards to the healthcare workers. Auditioning, looking into medical files, that's always a difficult one. But you need indeed, for answering the question, in my opinion, you need a specific group of employees who are dealing with those kind of examinations, and so you need a specific category for this, for on-field research based on the results of AI.
Okay, thank you.
For example, in Belgium, we have also medical inspectors who are medicines, and so they can also go to the doctors, for example.
Okay, thank you, Tom, for your question. Are we already connected with Mr. Xiuming or not? Not yet? Okay, I will throw the chance to Pak Somil. Please, Pak.
While we are still waiting to connect with Ms. Sungmi, and I see that she's connected, I just wanted to respond that HIRA does have on-site investigation, and in fact, on-site investigation is a defined sample picked up by the minister each year, and HIRA staff are drawn to form the teams. But now that Sungmi is there, I don't need to respond on her behalf, and maybe I can add experiences from other countries. Sungmi, over to you. I was trying to respond on your behalf while you were offline. Thank you.
Yeah, Mrs. Xiuming, can you hear us? I think you're still mute. You're still mute, I think. No, we can't hear you.
Okay, gotcha.
Okay, yeah, good. Please.
What was the question again?
Oh, okay. What Pak Mundi asked you is that Pak Mundi wants to know who conduct the investigation or the on-site investigation. Is it HIRA or the other institution? And the second one is, does HIRA have a special investigator to conduct that investigation? Is it right, Pak Mundi? Yeah.
Okay, I got it. Yeah. The on-site investigation is conducted by both HIRA and NHIS. And HIRA also operates special team composed of special investigator to conduct on-site investigation.
Okay, so do you do have a special investigator to conduct that activities? Is it right?
Yeah.
Okay. Is it enough? Okay. Okay, thank you. Oh yeah, another question from Bu Lily. Please, Bu.
Thank you. Well, actually, I was very interested in the prosecution of this fraud handling. Yeah, I mean, what I saw that you can also give sanction or punishment by calling off the license. You can stop the license from for the medical doctors there. In
terms of in terms of like a prosecution.
Yes, for the sanction.
License could be
the license.
Just suspended. Such as like 4 or 6 months.
Suspended. So you have the right, or you given the authority to suspend the license of the medical staff there when they are proved to.
We can request for the suspension of doctor's license to ministry. So the minister orders that to like suspend the rights of physician's license because the license is given by minister.
Oh, okay. And I also read that you may prosecute up to the prison. So it is very in Indonesia we never have a medical staff get into prison by the fraud, for fraud indication. So how do you do the steps before that can end up in criminal law in prison like that? Do you cooperate with other institutions also, or HIRA can do that?
Well, the criminal thing is stated at the law, so we cannot just do it by ourselves. We have to cooperate with other ministry, other organizations. But the criminal prosecution rarely happens in reality.
Okay, thank you.
Okay, thank you very much, Xiongming, for your great answers. Is there any question from the floor? Yeah, please. Oh, yeah, Natalie also. Yeah, I mean, you can, you first.
Thank you. Let me introduce myself. My name is Boni. I'm Attorney General in Indonesian Republic. I would like to ask to Ms. Xiongming about HIRA. You said that your system is detect for only for high probability. I would like to ask, how about the low probability? Is that HERA will also detect low probability, and how you can make scope for low probability or high probability? Is that? Thank you.
Yeah, thank you, Pak Mundi.
In
Yeah,
HERA,
please, Semi.
all healthcare claims should be reviewed by claims review at HERA. And then a result of claims review, certain amount of claims to test with high probability of fraud, like a high probability of suspected to have high probability of fraud or false claims, around like 5% of all claims going to on-site investigation subject for the efficiency manner.
Yeah, okay. Okay, thank you, Seming. Is there any other question? Oh, Natalie, please.
Yes, thank you. My name is Natalie, I'm from the ISA, and I have a specific question for Mr. Verdonk, but first, thank you very much to all for all the interesting presentations. So, we talk about AI, we talk about emerging technologies and everything that can help to detect and to tackle fraud in healthcare, but of course, all the emerging technologies give also possibility to fraudsters, and they can also go even quicker than we do, that's one thing, and also in a much broader scope, and fraud does not stop at the borders. So what are the projects that are currently, let's say, addressed within the EHFCN? Is it on a national level that you exchange your good practices, or are you also addressing it on an international level and a cross-border fraud in healthcare? Thank you.
Yeah, I think it's addressed to Tom, yeah? Is it?
Yes,
yeah.
yes.
Please, Tom, can you hear the Natalie question? Yeah, please.
Hi, Natalie. This is the hope. We've been former colleagues, so we know each other very well. So I think you are making a good point. One of the weaknesses for the moment is indeed that every country is more working on their national level, and we are sharing, of course, good practices. It depends also on the system of healthcare, because you have different healthcare systems towards the countries. But on the cross-border fraud or international fraud, there are much steps to take. One of the problems there is, of course, is the comparison of data. Every country has his proper data management, and so you can't always compare those data easily from one country to another. There are already some exchanges. For example, if a healthcare provider in a country is suspended for acting his work, sometimes there is an exchange to other countries, because healthcare workers sometimes starts just like that in a new country. There are some projects, but there's a lot of things to do there to become on that more on a European or international level. That's a very good point and a strong working point for the future.
Yes, thank you. And I also wanted to mention that the ISA has an MOU with the EHFCN,
yes,
and that we are going to work on a project together, so to be followed. Thank you very much, Tom.
That's for sure. Thank you, Mrs. De Wolf.
Yeah, thank you. I think I'm going to give opportunity for the last question from the floor. Is there any other questions? No? Is it enough? Okay. I think it's enough, but I have one question for Ibu Lily. So, do you think what will be the next development for AI in our scheme? Can you a little bit explain? Thank you.
Yeah, now we are still developing and not completed yet the AI system for verification process in secondary and tertiary facilities. While actually we also have primary care facilities that we pay in capitation, but usually we evaluate the primary care capitation or indicator is on the output side. on the output side. So we never really we never really evaluate how the process of delivery given in primary care, because we do that in capitation and the potential of fraud in capitation is under standard or substandard delivery. So how can we measure through AI the behavior from the PCare, from the primary care application, the data that's submitted, how they give medication, for instance, and procedures, how we can measure, is it standard, are they comply to standard or not by AI? I don't know if it's, is it possible to do that, because I'm not from the IT background. Maybe Pak Doni has to answer that. Can we do that with AI to measure the process of delivering services in the primary care while we pay them capitation based? Thank you.
Thank you, Ibu. Yeah, sure, we can do that as long as we get the data. And so we believe it. And so collaboration, of course. Okay, thank you. Please give applause to all our speakers. And thank you very much, Ibu. Thank you very much, Mr. Tom Farong, and also Ms. Ming, for your great presentation. We learned a lot from what you have presented, and I'm not gonna summarize all of this presentation, but I believe that we have so many lessons to learn, and the important thing that we have the optimistic that AI is clearly an effective tools to help us combating fraud. And please excuse me if there's any words, comments from me that not appropriate. But before we close this, wrap up this session, I have a pantun to deliver, like our President Director did. So pantun is, I think, I don't know, in English, is maybe it's a rhyming word. So, took a long flight from Geneva to Magelang. Usually Indonesian called cakep. Don't forget to go around and sing along. Let's fight fraud in place where we belong, so we can eliminate fraud for not so long. Thank you, and have a good afternoon. Thank you very much.
Once again, we would like to thank our respected speakers and also our moderator for successfully leading the second panel session. Can we have a round of big applause once again, ladies and gentlemen? Such an enlightening discussion and such an interesting presentation for all of the speakers. Thank you very much for sharing with us. And ladies and gentlemen, that is the end of the second panel session for this lovely afternoon about tackling fraud and eliminate waste based on machine learning and artificial intelligence. Well, ladies and gentlemen, this is our lunch time. So before we proceed to our third panel discussion for this lovely day, we would like to invite you to enjoy and to have our lunch session at the Stupa restaurant located near the lobby of this hotel. We will continue our agenda for the third session after lunch regarding interinstitutional coordination and collaboration to prevent and tackle fraud. Therefore, we kindly remind you to be back to this ballroom at 1:30 p.m. Java time. Please enjoy your lunch as we Indonesia say, selamat makan, selamat menikmati. Thank you. Distinguished guests, ladies and gentlemen, good afternoon. Welcome back to the ballroom of Pelataran Heritage Borobudur. How was your lunch, ladies and gentlemen? Is it good? Good. I see some of the menu coming from Thailand, Pad Thai, and also the famous beef rendang from Indonesia. We really do hope that you enjoy your lunch this afternoon. And after lunch, once again, we hope that we can recharge our energy and focus for the third panel discussion this afternoon. We come to the last panel discussion. The third panel session will discuss the matters on interinstitutional coordination and collaboration to prevent and tackle fraud. Ladies and gentlemen, I would like to introduce our distinguished moderator for this session. He is Senior Health Specialist and Cluster Lead for the World Bank Health and Nutrition Programs in Indonesia and Timor-Leste, and has been representing the World Bank team in the Joint Learning Network for Universal Health Coverage. Ladies and gentlemen, let's join me to welcome Mr. Somil Nakpal to the stage.
Selamat siang, good afternoon. Big welcome to the post-lunch session. This is usually a very difficult session, but I'm sure Pa Gufran and Pa Mundi asked me to do it for good reason. They may have wanted that I will be able to keep everybody entertained and happy. So you will find me trying to keep you entertained and happy throughout this session so that we don't feel any impact of that excellent lunch that we just had. So let's get started. Welcome once again. This is a very important session as we talk about the interinstitutional dimension of fraud prevention, detection, and elimination. As we were hearing from multiple country experiences in the morning, this is a responsibility that is not just with the health sector or with the health insurance agency. It is something that involves legal issues. It is something that involves enforcement. It's something that involves field presence and has to work with subnational governments. So a lot of elements here in being able to do that, and a lot of tools at our disposal across organizations. So let us try to learn from three different experiences that we will be able to call upon in this excellent session. So I will start by once again welcoming you all to this session. And let's keep it interactive and fun. We have three excellent speakers who will also keep it a lot of fun. But if not, I will find opportunities to trouble you. If I find anybody sleeping, I will give you a gift. Yeah. So please see that you will be spotted and on the camera, because I will come and walk to you for a gift. So try not to sleep, please, because it's a question of my ability to keep the session happy and lively. Okay, thank you very much. Let's get started with the session. Can we have the flashes, please? Will you be projecting the speaker names? If not, I can just invite them myself. Okay, our first speaker, of course, is Dr. Basant Garg, who's the Additional Chief Executive Officer and the Mission Director of Ayushman Bharat from the National Health Authority, Government of India. It's a pleasure, Dr. Basant, to welcome you. Welcome to the session. Thank you very much, please. Thank you very much. Okay, our second speaker, Dr. Mundi Harno. And we have an online colleague also from the Corruption Eradication Commission. Can I please invite the Zoom screen, please? Hello, Pahal. Welcome to the session. Salamat siang, Pa, and thank you very, very much for your time. Looking forward to hearing your thoughts. We have this very distinguished panel that is being able to talk to us. And so I'm going to not take a lot of time and already start with Dr. Garg as the first speaker. So if you could take the mic, we can start with our first presentation. You have about 15 minutes.
Okay. Okay, at the very outset, let me thank BPJS and our colleagues from Indonesia for hosting us so warmly. I would also like to thank the World Bank team for actually bringing me here and for making me able to interact with all of you. So I have a small presentation. In India, let me give you a brief background. In India, we are implementing the social health insurance scheme since 2018. We started out targeting 40%, the bottom 40% population, which was close to 400 million. Over the last 4 years, we are now covering 650 million people with our scheme, social health insurance scheme, which is close to 50% of our population. Can I have the slide, please? So healthcare in India is presently, we're trying to provide holistic healthcare under the Ayushman Bharat banner. So somebody asked me, what is Ayushman Bharat? Ayushman Bharat is a blessing, a health, well-being blessing for India. Bharat is India, and Ayushman is a blessing. So in a way, we are blessing our own people. So Ayushman Bharat. So it has 4 pillars. The Ayushman Bharat Prime Minister Jan Arogya Yojana. So this is the scheme which we are going to talk about. Another pillar is the digital mission, Ayushman Bharat Digital Mission. Then there is the Ayushman Bharat Health and Wellness Center, which is the remodeled primary health center, that is the primary health care, and the Ayushman Bharat Health Infra Mission. So this takes care of the infrastructure needs in all the rural areas in the field. The ABPMJ, the scheme which we are going to talk about, it targets secondary and tertiary treatment, inpatient treatment, for the bottom 40%. And it is implemented by the National Health Authority, which is a subordinate organization specifically created for this purpose under the Ministry of Health and Family Welfare, Government of India. And I am presently working as its additional CEO. Next slide. So it tells us the key features of the scheme. So the identification of beneficiaries was as per the socioeconomic caste census, which was done in 2011. So there is no cap on the family size, age, or gender within those families which are included. As of now, it is implemented by 33 states and union territories. Only 3 states have not yet implemented it, and they are implementing their own programs. So benefits can be claimed at impaneled public as well as private hospitals. So all the public hospitals and private hospitals which are impaneled, which follow a particular set of quality, they are implementing the scheme. The health cover is in Indian terms, it's 500,000 rupees per family per year. So this is the wallet size which they get. So it's $6.25 thousand US dollars per family per year. Scheme is funded by the central government as well as the state government, so in a ratio of 60-40. And it covers 1,690 procedures. We are expanding the health benefits package even as we speak. Next slide. So these are some of the key activities. The biggest concern is beneficiary identification and enrollment. As of today, we have been able to register and enroll close to 220 million people. So the size is 650 million, but all of that has still not been enrolled. There is empanelment of all the healthcare providers. We have to design our health benefits package. So I'll just focus to the anti-fraud measures. I think that is the topic we are all here for. And we design policies to prevent, detect, and deter frauds. Next. So our perspective on healthcare frauds, failure to detect fraud is bad news. If you find fraud, it is bad news too. So it's a dirty work. We see what we detect, but there is a huge element which we do not detect. So it's just a proverbial tip of the iceberg. It is a dynamic game. People learn, they learn to adapt, they learn to cheat. So we have to adapt as well. Success in detecting fraud is often taken as a failure to prevent. So nobody, rewards you if you detect fraud. And of course, people try to game it all the time. Investigation of fraud is only a tool. Actually, we need to prevent it, and there has to be a huge deterrence. So we'll talk about that. The last point is, at the international level, there has been attempts to estimate fraud. So, there are various sources which say that at least 3% of all claims could be fraud. In some countries, this has been seen to even touch 10%. So you can imagine, it's not that those countries have bad people, it's just that they have probably good detection practices. So next slide. Now this is the, my understanding of the difference between mistake, difference between waste, abuse, and fraud. So there could be some errors which could be quite genuine and which are mistakes. There could be, there could be a scenario where people are ordering excessive diagnosis and treatment. So that is an inefficiency which leads to waste. As was earlier, informed by Natalie, there could be, avoiding rules, bending of rules, which could be lead to abuse. And then, of course, there is flagrant fraud. So it's quite open and it's fully intentional. Next. Yeah, so I would like to, introduce you to what we are doing to start the process of detection of fraud. So we have developed this radar, the risk assessment, detection, and analytical reporting. It is a way of developing the various tools and identifying prima facie which states, which districts, and which hospitals and which procedures are the ones which are more prone to fraud. So this is where it all starts. As you can see, we are showing you the map of India, and within this map, for a particular date range, you can see the heat map. You can see which states are utilizing more, having more number of hospitalizations. So it is these heat maps, the intensity of the color tells you that these states are using more of the scheme. Next, please. Within that state, you can drill down to the district. Next, please. And of course, then within the districts, you have the hospitals, and within the hospitals, you can see which procedures are being, utilized more and more by the states. So this helps us understand, within each state, you can have a look at, which procedures are getting more used, or whether it is demand-driven, or whether it is supply-driven. So this you can also understand from this. You can have an absolute number. As you can see on the right, there's a place where you can select. Either it is absolute, or it could be normalized to, per 100,000 population. So you can actually see what people are actually demanding, what they are getting, whether it's actually, congruent with the demographics, or whether there is something there. So next, please. Now, similarly, that is for this particular hospital, you can see these are the procedures. Next. And the final one, we then analyze the outliers. We try to identify which hospitals, which procedures are actually not within the normal range or within the expected range. So there is a deviation, there's an outlier here. And of course, outlier also in the terms of time. So sometimes the frequency of a particular procedure suddenly rises. So we also come to know from this. Next. Now, this analysis is one of the inputs which help us develop triggers. Now, triggers are nothing but algorithms. They are algorithms which are run by the computer when they see all these claims. So, how do we develop these triggers? There is medical audit, there is radar analysis, there are some internationally established triggers, and then of course we discuss all this. We also discuss how to implement this, what is the technology, writing the code, and then these triggers are actually run on our beneficiary identification system and the transaction management system. So we are having two systems here. One is the one which contains the database of all the beneficiaries, and then there is the transaction system, transaction management system. So these triggers are applied. After these triggers are applied, we do a medical audit and we check what is the hit rate. So hit rate is that these triggers, they send out a particular percentage of suspicious cases. And now out of these suspicious cases, how many of these suspicious cases are actually fraud? So that is the hit rate. So when I say a hit rate of more than 30%, it means that out of 100 suspicious cases, 30 cases finally prove to be fraud. So if that is so, we are taking this trigger and actually applying it on our system to all the cases, to 100% cases. And we allow this system, this trigger to run, and we monitor it. Now, when the hit rate, as I told, it was 30%, we were checking it on a sample, on a selected sample. But when we apply it pan-India, we are just looking for a hit rate of 10%. So if the hit rate is more than 10%, we are good. We keep continuing applying this trigger. But if the hit rate is less than 10%, again, we have to reevaluate how effective is this trigger. So this way, it's a continuous process. Let me tell you, we started off with more than 60 triggers, and today we are only using 25. So we have discarded certain triggers because we found that they were wasteful. They were probably not giving us the desired result. Next, please. Now I would like to tell you how give you a flavor of what these triggers are. As was highlighted in the first session, they could be driven by data. Now, the llama and dama is basically left against medical advice or discharged against medical advice. It would be similar to a case where the patient has been booked with a serious condition, but he's discharged early, as was highlighted in the first session. So this is covered in that. And, hospitals which are giving us more and more of such cases, so they are flagged. So they are also selected from there. Then stroke cases, those are also identified and they are flagged, which are, which are deviating from the standard treatment guidelines. So those are flagged. I'm just giving you examples. Then there are certain triggers which are natural language processing driven. So for example, this is a very common trigger we are using, and we found it very, very high hit rate. It has a hit rate of close to 65%. Now, hospitals in India are trying to book most of the hypertension cases as accelerated hypertension. So they try to book it as that and probably upcode it. So this trigger is very effective. So I'm just telling you the kind of triggers we are using. Then we use image analytics. We are analyzing images which are uploaded to our system, to the NAS, and we found that many of these images are used duplicate. They are used in the same image is used in multiple cases. So that is also an important trigger for us. And of course, then we have developed some triggers which analyze the social patterns. For example, the same, there's a person, Prime Minister Arogya Mitra, who functions at the hospital level and who gets his incentive when he gets more and more patients under the scheme. Now, if in case there is an association of this person with the health facility or the beneficiary, so this could lead to fraud. So we also analyze that. That is one of the triggers. Next, please. Now it will just to give you a flavor of how many, what percentage of suspicious cases, what are the various kind of mistakes or frauds or abuse cases. So we found that, there are certain rule-based triggers. For example, you cannot have a gynecological procedure in a male. So 79% of cases would fall under such rule-based triggers, which could be maybe because of some error at the time of data entry, or which could be sheer foolishness. But such things are there. 5% of cases are, suspicious cases are upcoding, 7% is abuse, and upcoding being a part of abuse, and 6% is ghost billing. So, the services have not been rendered at all, but still it is there. Next, please. Now, we are using 4 specific triggers on the beneficiary identification, and as you will see, the hit rate of these triggers is very high. So the first one is, there are instances when more than 5 members are added to the same family. As you can see, the hit rate of this trigger, added member, is 62%. In 62% of the suspicious cases, this trigger has found the fraud, actual real fraud. So again, so this has led to deletion of those members, disablement of those cards. Then we do this fuzzy analysis which checks the demographics, the name, mistakes could be there, or there could be duplication of names. This trigger is also has a very high hit rate. It is giving us a hit rate close to 80%. So 4 out of 5 suspicious cases are actual fraud. So we are very happy with these triggers. Then there is, of course, a trigger for ghost beneficiaries having multiple cards. So this trigger has a lower hit rate, but we still keep it because this is quite prevalent. And then there is an invalid beneficiary image. So at the time of uploading an image, a bad image or a totally irrelevant image is uploaded. So this trigger also has a high hit rate. It has a hit rate of 90%. So such cases are, are sought out. Next, please. Now, this was a flavor of what we are doing and how we are, trying to capture fraud. I have deliberately, I'm not sharing the data of the total number of fraud cases. I'm just concentrating on the methodology, of how we are developing these triggers. As, has been rightly pointed out by many of you, these triggers are, they could be leaving out a large number of cases. There could be a case where a trigger which is giving us a hit rate of maybe 5 or 6%, we are discarding that. That could be the case. Those we are taking care of not through the triggers or the machine mechanism. Those we are taking on a the feedback we get from the social media, feedback we get from the field, from the states. So the scheme is implemented in India. NHA is at the federal level. There is a state health agency at the state level. So all the suspicious cases which are churned out, they are sent to the state health agency, which has a state anti-fraud unit. So they have to decide on the action to be taken on all these suspicious cases. So there is an element of center-state collaboration. We share risk scores of providers to insurance agencies. We publish framework, we publish guidelines and our policies, and there is information sharing with the General Insurance Council. Next, please. Now, this is again, some of the collaboration is happening in India, but it is between the center and the state. There is limited collaboration, information sharing between the health sector and the financial sector. But probably this is what we need. We need more and more cross-sector information sharing. We need public-private partnership. We were just discussing that we probably also need, sharing of this information, sharing of the best practices at the international level also. Now, this IRDAI is the national insurance regulator for India, and we presently have a joint working group with the IRDAI. We are looking at ways to, disseminate this information to the private insurers and also maybe consume their information to help prevent frauds. This is the FICCI. FICCI is the national body of industry body for India, and a lot of our large corporate healthcare providers, they are members of FICCI. So we use FICCI also to, nudge healthcare providers because they are a huge element in this. And of course, there are accreditation agencies. We want to make use of them. Next, please. This is some of the things which I thought were necessary or, very, very, very much needed for information sharing. The strategies of fraud prevention and fraud detection. We need to develop digital technologies as public good. We were discussing, Somil and me and Ajay, we were all discussing how India badly needs digital technologies, and with the kind of numbers, with the kind of the hospitalization cases every year which we are managing, we really need more and more digital technologies. We need, of course, legal and managerial strategies. I think in one of the sessions earlier, the speaker highlighted how a court ruled on what what the triggers were or what AI was doing, in detecting such fraud cases. So we need to be smart. Otherwise, whatever we do would be open to a court, to judge, and maybe the person who we identify as a fraud, he ends up claiming more from us. He ends up, claiming damages. I think there is a case for naming and shaming of proven, healthcare providers who are, doing all the wrong practices. And I'm sure if we are sure of it, there wouldn't be a case for any defamation or anything. We need to share information about action taken on frauds. So we need to communicate so that there is a deterrent. We need to tell the people also, empower the public as we had discussed. So if more and more citizen organizations, patient organizations are aware about the kind of fraud which happens, probably there will be more discussion about it, there will be more information which will be provided to us. And then, of course, publications and research studies. A part of it could be, case studies in other countries, in other setups, which we can, maybe in the private sector, with private insurance companies, or maybe in public health schemes. So all those case studies could also help us understand how people game the whole system. Next. Next slide, please. Okay. Right. So let me tell you that, we also have employed a vendor, a private company, which helps us in this whole mechanism. And recently we conducted a study wherein we found that the cost which we are paying to the vendor, the vendor is helping us 10 times in preventing fraud. So, that could also be a way, because we always need more and more expertise. We need people to help us. We are not always right, and of course, if somebody's, helping us to detect and prevent fraud, it's a service. I think probably this is somebody could maybe look it up. I think this is the last slide, so we need not bother with the last one.
While they're waiting for the slide, I just wanted to compare. Dr. Garg was talking about Ayushman Bharat. We have a very similar term in Indonesia, Dirgahayu, Indonesia.
Dirgahayu, yes.
Ayushman means the same as Dirgayu or Dirgahayu. So the name of his program is Ayushman Bharat, which also means, if you are saying in our thing, Dirgahayu Bharat or Dirgahayu Indonesia. So we
So
use.
I think Dirgayu is also a Sanskrit word.
Sanskrit word.
Yes,
So that's.
it means have a long life, have a.
Ayushman means the same.
Yes,
Be
healthy life.
stay healthy, stay long lived. Yeah. So very similar word. And very interesting cross-sectoral collaboration opportunities. Is there another slide, Bhubidi?
This is the last one. Yes, I think then we.
Okay.
Thank you then.
Well, thank you very much. And of course, a very nice listing of potential collaborations that can be done on information sharing.
Struck me. There is just one slide left in which there were various international organizations and agencies which we would like to collaborate with. So that was probably some of those agencies which were there. So I think that slide has got stuck. So I just remember now. So I'll probably, while we are having some question and answers after all the speakers have spoken, I think then we can have that slide as well. Thank you.
Yeah, I was trying to see if I had that slide ready. Okay. There's always some suspense to be kept, right? It's even more exciting. So there's something hidden that we will share later. Let's see if we can get that. Yes, collaboration is key. Okay.
Okay. So thank you for that. So this is actually some of the international agencies. One of the speakers today was from EHFCN. So we are really looking forward to having more and more collaboration. In fact, I think we in Asia also, we probably need to have some such agency which can help all the countries. So many of them are present here today. So we also need probably an organization which can help us. Thank you. It need not, as rightly said, it could be a collaboration between governments, or it could also be a non-government private agency. I mean,
or a network.
Yes, or a network. It need not be because making it more and more government-oriented could, lead to a lot of things. So it could be more non-government organization kind of a thing. It could be anything, yes. But we are, of course, open to collaboration. Thank you.
So Dr. Basant ended with collaboration is key, and Pak Gufran was mentioning over lunch about the importance of networking. And I think we already have a union of minds that we can think about as we move forward in this session. Let me take this opportunity then to segue to another very important collaborator in the space of fraud detection in Indonesia, which is the National Corruption Eradication Commission. And Pahal is waiting for us online very patiently. Pahal, this is our privilege to invite you to be the next speaker. I hope you can hear us, Pa. And if the organizers can switch to the Zoom. Thank you very much. Over to you, Pahal.
Thank you, Dr. Somil, for a nice moderation. Agree with you. It's a very hard time after lunch, so it's very, very unlucky for us to let's say provide numbers, bad news, problems, etc. But I believe on you, so hope that everybody can look at the a big pictures on how fraud in health sectors and social insurance sectors in particular, which KPK get involved due to the law told us to do those things. Coordination of public service institutions, so is coordination, of course, to prevent corruption. And then the second task is to monitor any government system and provide recommendation for improvement. And recommendation will be follow up every 6 months and reported to the president if there's some not conducted. So we jump into these health sectors or social insurance, social health insurance in particular, due to these two tasks stated in the law. But ladies and gentlemen, at this international seminar, fraud in social health insurance, prevention, detection, and elimination. From KPK, I would like to say thanks to BPJS Kesehatan. It's our long partners, actually, to Prof. Gufron and other directors, my regard to you all. I believe the BPJS Kesehatan getting better now, and in particular to all participants. And I saw on Zoom, most of the participants come from BPJS, from a local government level. So my apology, not come offline there, and my apology again to speak in Bahasa in order to deliver this while my presentation will be in English. So my apology, Dr. Somil, I will be speaking in Bahasa. I have several slides actually, so please, if I can have my slide presented. Okay, next slides, and another next one. Oke, Bapak Ibu dari BPJS Kesehatan dan peserta international seminar yang saya hormati, saya merasa beruntung pada kesempatan kali ini karena sekaligus gitu ingin menyampaikan ke Pak Gufron dan para direktur gitu ya, ini kesalahan KPK dengan keterlibatan KPK secara khusus dalam handling fraud, prevention dan seterusnya. Yang kami baca begitu bahwa tidak semua fraud tentu saja menjadi korupsi yang ditangani KPK gitu ya. Tidak semua fraud gitu karena banyak hal yang memang bukan wewenang KPK. Tapi saya Pak Prof Gufron dan para direktur serta jajaran BPJS, saya ingin ingatkan gitu ya bahwa KPK hadir bersama BPJS Kesehatan sejak transisi awal gitu dari penggabungan asuransi kesehatan menjadi BPJS. Kita ingatkan yang pertama, kita ingin untuk penerima bantuan iuran yang 100 juta orang kurang lebih waktu itu, kita ingin itu harus ber-NIK untuk menjamin bahwa yang diberikan 25.000 bantuan iuran itu orangnya memang masih ada di Indonesia. Dan alhamdulillah setelah beberapa kali, mungkin 2-3 tahun, sekarang sudah hampir bisa dipastikan bahwa data dari Kementerian Sosial, DTKS, dipindahkan ke Kementerian Kesehatan, dan diberikan dananya ke BPJS, sudah ada NIK. Paling tidak kita bisa bilang bahwa PBI itu sekarang tidak ada lagi yang fiktif orangnya. Urusan dia miskin atau tidak miskin itu lihat dari DTKS Kementerian Sosial. Yang kedua, saya sendiri ingat pernah menulis surat, Pak, ke ratusan pemerintah daerah yang punya tagihan BPJS Kesehatan. Masih nunggak sisa-sisa yang dulu jam kesda segala macam. Dan kita tulis surat juga bersama-sama dengan BPJS Kesehatan dan Kementerian Kesehatan tentunya ke Menteri Keuangan untuk memotong saja jalurnya. Tidak usah dari pusat kasih ke daerah, daerah dianggarkan baru bayar iuran BPJS Kesehatan buat PNS daerah. Kita bilang potong aja langsung dari DAU. Dan saya rasa ada peraturan Menteri Keuangannya sudah dilakukan gitu, karena ada kasus Bupati Subang waktu itu di KPK gitu, antara lain menggelapkan dana untuk pembayaran iuran BPJS Kesehatannya. Gitu. Oleh karena itu, di awal kita bilang koordinasi ini menjadi sangat penting. Saya pada paparan kali ini ingin menggambarkan bukan betapa runyemnya, tapi betapa banyaknya gitu instansi yang harus ikut serta mensukseskan BPJS Kesehatan dalam kerangka JKN. Kami dari KPK selalu bilang, Pak, tidak ada social health insurance sebesar BPJS Kesehatan. Jadi kalau cerita orang komplain 1.000-2.000 orang bukan kita anggap kecil, bukan Pak. Dari KPK selalu bilang tunjukkan yang bisa menghandle asuransi sebesar BPJS Kesehatan. Bukan minta maaf, bukan, tapi ini program mulia dan harus sukses. Dari awal Pak Gufron kita udah selalu di posisi itu. Orang boleh menghina dokter, bilang nih dokter komersil obat ini. Dia bilang iya, jangan lihat ini Jakarta Surabaya dong. Lihat dari Saung Melaki sana, gitu kan. Nah oleh karena itu kita percaya BPJS Kesehatan ini sekali sudah ditetapkan pemerintah, ini harus berjalan dan mencapai universal health coverage, gitu ya. Nah kita lakukan juga beberapa kajian teman-teman dari BPJS Kesehatan, antara lain untuk mendukung kita bilang sistem perawatan kesehatan gitu. Jadi kita juga dorong bersama Kementerian Kesehatan, bersama asosiasi rumah sakit pusat, rumah sakit daerah, rumah sakit swasta, dan bersama Ikatan Dokter Indonesia terutama kolegiumnya gitu, bagaimana membangun clinical pathway. Karena dari situ kita bisa lihat bahwa kalau jalurnya demikian, maka berapa biayanya bisa direview. Dan itu menjadi basis untuk menjawab klaim bahwa terlalu rendah. Oleh karena kita bilang hanya bisa kalau kita jelas gitu, sama clinical pathway. Pada saat yang sama saya ingat dengan diskusi keras dengan ID waktu itu, kita bilang fraud itu dasarnya harus kita cegah. Lantas dari ID bilang, loh kenapa Bapak bilang fraud? Gitu. Kalau tidak ada standarnya, saya akan berusaha supaya pasien saya sembuh. Gitu. Kalau nggak ada standarnya, saya nggak mau dibilang fraud. Gitu. Jadi baru level itu. Sekitar 4 tahun yang lalu, Prof. Gufron gitu diskusinya di KPK gitu. Karena kita ingin juga bahwa kita nggak menutup mata juga. Ada memang upaya kesehatan yang ingin supaya sembuh. Tapi kita nggak menutup mata, ada juga rumah sakit yang nakal juga ada juga, Pak. Kita akan sampaikan di slide berikutnya. Jadi dengan Asosiasi Rumah Sakit, dengan Ikatan Dokter Indonesia, dan kolegiumnya, serta Kementerian Kesehatan, kita bangun secara fundamental healthcare system. Lantas dari BPJS ada juga dana kapitasi ke puskesmas, kita rekomendasikan juga harus berbasis kinerja. Karena kita bilang preventif, lantas rehabilitatif dan promotif itu harus ada, bukan hanya kuratif gitu ya. Dan sekarang sudah dilakukan, terima kasih gitu, kita lihat juga ketidakadilan tanda kutip oleh puskesmas itu bisa sekarang diperbaiki. Untuk itu, waktu itu kita bekerja sama dengan Kementerian Dalam Negeri untuk menginstruksikan kepada pemerintah daerah tidak boleh mensubstitusi dana kapitasi. Karena kita membaca ada gejala bahwa Dinas Kesehatan melihat bahwa puskesmas sudah punya uang dari BPJS dalam bentuk dana kapitasi, dia ada beberapa tidak semua, mensubstitusi. Jadi kegiatannya justru tidak turun ke vaskes yang FKTP gitu. Karena dia bilang kan dia udah punya uang dari BPJS Kesehatan gitu dalam bentuk tenaga pelayanan kesehatan. Lantas untuk obat pun kita dorong bahwa generik diwajibkan. Hanya belinya harus lewat katalog. Saya ingat dalam pertemuan dengan sekitar 1.500 kepala rumah sakit daerah dan dinas kesehatan, kita bilang Anda harus masukin RKO. Kalau tidak masuk RKO, Anda tidak boleh beli obat dari katalog. Kalau obatnya ada di katalog, Anda tidak boleh beli dari tender. Jadi kita dorong semua dan alhamdulillah bahkan rumah sakit swasta pun sudah ingin masuk katalog waktu itu untuk obat generik. Yang belum sempurna adalah alat kesehatan. Kita dorong juga ke katalog dan alhamdulillah di bawah Menteri Kesehatan yang baru setuju bahwa ini katalognya sektoral. Jadi Alkes yang pasarnya 30 triliun lebih itu, 80% dibeli pemerintah, itu sekarang sudah mulai masuk dalam katalog khusus dan dibeli oleh pemerintah daerah serta seluruh pengguna di Indonesia. Kita harapkan sebenarnya dari katalog alat kesehatan bisa didorong TKDN. Jadi penggunaan komponen dalam negeri yang lebih banyak. Nah, khusus untuk fraud handling, pada slide berikutnya. Kita lihat dari sistem yang diadopsi oleh BPJS Kesehatan, kita kehilangan satu komponen namanya fraud handling. Oleh karena itu, bersama dengan tim dari BPJS dan Kementerian Kesehatan, tim KPK ke Amerika waktu itu. Kita lihat bagaimana sih best practice-nya di Amerika khusus untuk fraud handling. Jadi bagaimana mendeteksinya, bagaimana menghindarkannya, dan bagaimana menyelesaikannya. Pulang dari sana 2017 kita buat 3 gugus tugas. Jadi Kementerian Kesehatan, BPJS Kesehatan, dan KPK ada dalam 3 gugus tugas itu. Antara lain gugus tugas membentuk guidelines bagaimana menghindarkan fraud, lantas gugus tugas yang lain gitu ya, dan yang terakhir gugus tugas bersama kejaksaan untuk bagaimana menindaklanjuti kalau memang fraud itu terbukti dengan frame berpikir yang sama. Karena teman-teman kejaksaan juga mesti dibilang ini health sector agak beda Pak, gitu ya. Kita bilang kalau rumah sakit kabupaten cuma 1, dia ketemu fraud, kita hukum dia ditutup, selesai sudah. Gitu. Satu kabupaten bisa protes sama kita. Oleh karena itu, kita ingin kasih gambaran ke teman-teman penegak hukum, begini loh fraud di kesehatan yang benar-benar fraud. Dan 2018 kita piloting, gitu ya. Ini nih guidelines-nya, coba di lapangan jalan apa enggak, gitu. Dan 2019 akhirnya keluar regulasi dari Kementerian Kesehatan untuk fraud prevention and handling. Bapak Ibu sekalian, pada slide berikutnya saya dan KPK bersama BPJS dan Kemenkes melakukan langsung tinjauan di lapangan. Kalau dibilang audit enggak juga gitu ya, tapi mirip-mirip itu, dan seperti yang dari India kasusnya sama. Unnecessary treatment di katarak gitu ya. Kita lakukan sampling di 9 rumah sakit di 3 provinsi. Rumah sakit daerah juga dari situ. Kita lihat 24 orang, jadi ini tim besar, tim KPK, nggak ada yang dokter Pak, jadi kita berserah saja pada dari Kementerian Kesehatan dan BPJS. Lantas kita lihat juga fragmentasi treatment billing. Kita lihat juga service yang di cancel tapi tetap ditagihkan gitu ya. Dan yang paling penting tentunya tidak ada clinical pathway. Yang sampai sekarang salah satu rekomendasi kepada Kementerian Kesehatan adalah menyelesaikan sekitar 70 clinical pathway untuk esensial, penyakit esensial di Indonesia. Dengan Bu Nila terakhir baru 40-an, dan saya juga mesti minta maaf karena sesudah itu belum lagi kita lihat secara detail bagaimana clinical pathway ini dibangun untuk penyakit esensial di Indonesia. Masih ada juga kita temukan fragmentasi, unbundling, phantom billing pasti ada, unnecessary treatment gitu karena clinical pathway tidak diaudit gitu. Dan sekali lagi kita lihat karena tidak ada auditnya, basisnya jadi lebih sulit. Bahkan beberapa rumah sakit sebenarnya tidak qualified untuk mengklaim di tipe yang dia klaim. Kalau dibilang saya tipe B, sebenarnya kalau tim waktu itu lihat Anda tidak memenuhi syarat untuk tipe B, sebenarnya klaimnya tidak di level tipe B. Jadi kita masih lihat beberapa yang kita sebut fraud, tapi tidak semua ini disebut korupsi. Tidak semua disebut korupsi. Kalau dia fiktif, jelas dia korupsi, gitu ya. Tapi kalau dibilang tidak ada clinical pathway, saya ambil cara yang lain lagi, gitu, ujungnya lebih mahal, iya, gitu. Tapi kita bilang susah, kita bilang korupsi. Gitu. Jadi oleh karena itu kita sampaikan bahwa ini loh masalah di lapangan, kita harus selesaikan lewat 3 gugus tugas utama inspektorat, gitu ya, atas dari KPK, kita mendesain panduan pencegahan fraud untuk semua pihak, bukan hanya BPJS, rumah sakit, sampai penyedia jasa dan alat kesehatan. Kita sampaikan. Lantas ada juga grup untuk mendeteksi. Nah ini yang agak-agak Ikatan Dokter Indonesia secara terbuka tidak ingin, gitu ya. Ini kenapa harus ada begini? Tapi kita bilang ya nggak bisa juga, gitu. Kita berasumsi semua fasilitas kesehatan itu orang yang baik dan jujur. Kalau sistemnya kuat, gitu ya, ada orang yang masih keluar dari sistem, ya kita harus tindak, harus ditindak. Oleh karena itu BPJS, pengaduan masyarakat dari KPK, gitu ya, dan BPKP kita mendesain, lantas kita coba, gitu ya, panduan ini, dan hasilnya seperti pada slide sebelumnya. BPKP sendiri secara khusus melakukan audit karena waktu itu disebutkan dalam kondisi defisit. BPJS satu-satunya cara adalah menaikkan iuran. Kami secara khusus menulis surat ke Menteri Kesehatan dan Direktur BPJS bahwa ada setidaknya 8 cara yang bisa dicoba untuk mengatasi defisit. Tidak menjamin defisit hilang, tapi ada beberapa improvement yang bisa dibuat gitu supaya defisit ini bisa membaik atau mengecil pada saat itu. Antara lain, yang saya ingat ini Pak Gufron, ada co-payment gitu, udah ada loh peraturan Menteri Kesehatannya 10% co-payment gitu, kenapa enggak dikenakan untuk orang yang apa iya harus disamakan dengan orang yang secara adalah iuran. Ya, saya bilang ya enggak apa-apa, Pak Gufron dan para direksi beruntung pada saat ini tidak berjalan dalam kondisi defisit. Saya bilang, kenapa kalau defisit jadi concern KPK? Saya bilang, kalau Anda punya tagihan 10, uangnya cuma 4, gitu, maka yang terjadi adalah dulu-duluan mana yang mau dibayar. Pada saat itu, sistem sudah ada. Kalau 4, maka nomor 1 sampai 4. Udah pasti, tapi sistem terpaksa di-bypass. Karena dananya cuma ada 4, yang nagih 10. Jadi caranya adalah ya bikin diskresi, kita bagi rata, atau yang swasta duluan, nanti yang pemerintah belakangan. Yang ini kita bilang menimbulkan resiko. Jadi kenapa KPK concern dengan defisit BPJS? Karena kita bilang seketika dia defisit, resikonya muncul. Keputusan pemberian pembayaran. Itu yang kita lakukan, dan yang terakhir ada resolution working group, gitu, ada BPJS, ada KPK, ada seluruh inspektorat, ada ID tentunya. Bagaimana sih kalau udah terjadi fraud itu yang memang karena sistem, gitu. Jadi kan tidak bisa juga gitu diberi sanksi seperti saya bilang. Ini RSUD cuma satu di kabupaten. Kalau dia dikenakan sanksi dalam bentuk pemutusan kontrak, apa mungkin? Tapi kalau didiamkan juga, ya nggak bisa juga kita biarkan gitu, katakanlah phantom billing gitu dilakukan terus-menerus, atau katakan waktu itu yang saya ingat fisioterapi yang tidak dilakukan tapi diklaim juga sebagai paket, ya seperti itu kan tidak mungkin kita diamkan gitu. Oleh karena itu Bapak Ibu sekalian, sekali lagi kita terima kasih Pak gitu ya, bahwa kalau kita lihat dari kejauhan gitu, kelihatannya ini sudah jauh lebih baik ke BPJS Kesehatan, tapi percayalah Pak Gufron dan para direksi serta jajaran BPJS Kesehatan, KPK full mensupport upaya pencapaian universal health coverage. Bahwa ada fraud di dalamnya pasti. Yang kita desain adalah biarlah BPJS Kesehatan, ini kita belajar yang dari kunjungan ke Amerika, yang dari BPJS Kesehatan punya sistem untuk mendeteksi pada level operasional, dari klaim dan sebagainya, yang saya percaya database-nya sudah luar biasa banyak. Yang waktu itu kita tagih adalah Inspektorat Jenderal Kementerian Kesehatan, seharusnya melakukan yang seperti di India kita sampaikan, kita lihat di paparan tadi di radar. Melihat outliers yang strategik besarnya lah gitu, meninjau tarif apa iya udah begini gitu. Waktu itu kita sempat dalami juga tentang inasi bijis misalnya, ini kapan direvisi, misalnya yang mana revisinya gitu. Itu saya pikir tugas regulator gitu ya. Oleh karena itu pada tingkatan strategis preventing fraud itu harus dilakukan oleh Kementerian Kesehatan. Sementara pada tingkatan operasional bisa dilakukan dan harus dilakukan oleh BPJS Kesehatan. Itu desain besarnya, bahwa ada guidelines sudah oke gitu ya, ada deteksi sudah berjalan di BPJS Kesehatan, saya juga tahu beberapa gitu di Kementerian Kesehatan, mungkin pada level strategis yang mesti didorong lebih banyak gitu. Tapi yang lebih penting lagi, dan kita harus hindarkan membawa ke aparat hukum. Tapi tidak boleh juga dihindarkan kalau terus-terusan menerus dilakukan fiktif, dia pikir BPJS Kesehatan ini salah satu sarana untuk bikin duit oleh rumah sakit atau klinik atau penyedia fasilitas kesehatan. Dan sayangnya memang upaya ini tidak berjalan sesudah pembentukan task force. Waktu itu kita bilang sesudah guidelines ini ada, kita harus lakukan terutama dengan teman-teman kejaksaan. Seperti apa sih sektor kesehatan, mana fraud yang bisa dibawa. Saya ingin dia sembuh, hari ini dia sembuh. Ya sudah, gitu kan. Bahwa kalau nggak ada clinical pathway kayak apa, gitu, kalau standarnya terlalu rendah, padahal orang ini butuh 3-4 kali, sementara dia bilang tidak ada cara buat itu, ya dia bikin 3-4 kali. Nah itu Bapak Ibu sekalian yang kita ingin dari KPK meneruskan Pak, gitu ya, bahwa sudah saatnya gitu. Kita nggak mau juga dengar bilang rumah sakit bahwa kalau ini dengan BPJS Kesehatan gitu ya, berkontrak atau segala macam, kelihatannya yang pasti pidana nggak bakal ada. Padahal kita bilang, kita tahu beberapa juga harus pidanakan. Nah kita tidak ingin, tapi tidak bisa juga menghindari Pak. Oleh karena itu kita berharap ke depan bahwa kita bisa update Pak guidelines-nya, dan kita boleh sosialisasikan bersama dengan Kementerian Dalam Negeri, dengan Menteri Kesehatan udah pasti gitu, sehingga semua rumah sakit punya satu bahasa, tapi lebih penting dari itu resolusinya, karena kita lihat banyak sekali pertanyaan, komplain tentang di mana mekanisme klaim, berapa tarif klaim, dan hal-hal teknis lain yang kita pikir harus kita respon segera gitu, supaya jangan atas alasan itu maka praktek itu terjadi terus. Pada slide berikutnya dan yang terakhir ini mungkin kira-kira action gitu, dan seperti biasa kita ingin sebenarnya ini lebih implementatif, lebih bisa diimplementasikan sehingga sekali lagi kita capai universal health coverage, institusinya kuat, sistemnya berjalan, dan fraud-nya bisa di-prevent, bisa dicegah ketimbang ditindak, Pak. Jadi kalau sekarang tidak ditindak secara masif gitu, karena kita pikir belum cukup instrumennya. Hanya pada suatu saat tentu saja harus dilakukan penindakan sepanjang pencegahannya, guidelines yang kita buat harus diupdate kembali, dibuat satu bahasa, Pak, dan kami dari KPK siap bekerja sama dengan BPJS Kesehatan dan Kementerian Kesehatan seperti beberapa tahun yang lalu. Ini agak-agak ke belakang gitu, karena saya juga baru lihat juga, oh iya kita nggak punya portfolio yang cukup ya dengan Kementerian Kesehatan, dengan BPJS Kesehatan secara khusus. Atau karena kita tidak defisit gitu Pak Gufron, jadi nggak apa-apa gitu kita bilang untuk yang baik lah gitu. Oleh karena itu sekali lagi Bapak Ibu sekalian, peserta seminar internasional yang saya ingin sampaikan adalah yang pertama, tidak mungkin BPJS Kesehatan bisa mencapai target universal health coverage tanpa koordinasi, tanpa kooperasi dengan kementerian, lembaga, dan asosiasi, profesi maupun penyedia fasilitas kesehatan. Dan itu sudah dilakukan sekarang, gitu, dan kita bilang harusnya lebih erat lagi. Yang kedua, ada fraud, iya, tidak semua jadi korupsi, tapi harus dicegah. Selama ini sudah terjadi, rasanya perlu kita revisit, kita lihat lagi, dan kita dorong lebih implementatif. Sehingga pada akhirnya kita bisa bilang bahwa target bisa dicapai dengan efisien, dengan efektif tentunya, dan korupsinya minimum. BPJS bekerja pada pada level operasional untuk mendeteksi, gitu, dan kita harap Kementerian Kesehatan juga memainkan perannya yang tepat. Demikian dari saya, mohon maaf kalau ada yang salah, dan Assalamualaikum warahmatullahi wabarakatuh. Terima kasih.
A big round of applause. Pahal, we were worried that this was a difficult session post-lunch, but looks like everybody is energized and everybody is very happy, including me, to see such a human face of the Corruption Eradication Commission. Normally in my country, if we talk about the corruption eradication team, we are all very scared. But here we have a very happy, healthy and human face, which is a very, very well-informed face. And I think the points that Pahal made are actually something that even very informed global experts on health policy, including our friend Ajay Tandon and many others, would say precisely the very important points on what needs to be done, including clinical pathways. So I think fraud are things, some of that are already in progress. We are working with BPJS on the World Bank side as well on some of those. So Pahal, I think some of your guidance has already been incorporated. But I think a very important point that was made on having a task force, a regular mechanism for on-site action, something that Pamundi brought up in the morning session, is something that we must really think of and building upon Pahal's discussions today. I just wanted to also maybe take this opportunity to react to one point that Dr. Basant made earlier, which is whether fraud is bad news. Yeah, it's not seen as a good investment. Actually, if you talk to the insurance industry, the private insurance industry and the reinsurance industry, they say one of the best investments you can make is in fraud prevention, because every dollar you spend, you may actually end up, every dollar that you put on fraud prevention, you actually save $10 to $20 of public money. And that's where I think we need to make the economic case of investing in fraud prevention, and particularly deterrent action. So not only when there's a complaint or when there is something that we see as a trigger from AI, but also things on a sample basis, so that everybody has a small chance of being visited by a task force or by a team, and that creates the deterrence with, of course, strong eventual action if there is a case that is found. And that is the segue to invite Pamundi, who will be talking about the interinstitutional collaboration in the Indonesian context, building upon the discussion that we just had. I remember, Pamundi, 3 years back, I moderated a previous session again with India and Indonesia on the panel, which was in Prince Mahidol conference in Bangkok, and we had called it Two Giants Go Universal. And I think these are the two giants of the global healthcare space which are going universal, going towards universal health coverage. And very good to see these giants talking in a very similar language.
No, India is still a little distance away from universal. So we are huge, but we are not universal as of now.
But going 600 million is a very large number. So I think the intent to go universal and two giants going universal is like a very true picture of the intention of these two very large countries and today talking the very same language. And I'm just fortunate to recall that I am in a similar panel moderating the same two countries in a context again. So Pamundi, over to you for your presentation, please. Thank you.
Thank you, Pak Somil. India big giant, Indonesia middle giant. Okay, thank you very much, ladies and gentlemen. I want to share BPJS Kesehatan experience to handling how to manage anti-fraud in JKN system, especially how to improve collaboration among stakeholders to minimize the JKN fraud. But apologize, I will speak in Bahasa, so you can get more explanation in our presentation than in English. Next slide. Jadi jadi hybrid Indonesia and English. If we are talking about the fraud, there are main activities in managing the fraud. First, about the fraud prevention, fraud detection, and fraud handling. And in all aspects, all steps, we need cooperation with other institutions, with other relevant stakeholder, because BPJS Kesehatan absolutely cannot manage anti-fraud activities lonely. We need support from other relevant stakeholders, especially from KPK, from Health Facilities Association, from Doctor Association, from a local government, from Attorney General Office, and etc. I want to share our experience how to manage the anti-fraud and how collaboration among the institutions is very needed for us. Dalam fraud prevention itu ada beberapa aspek yang penting untuk kita perhatikan. Pertama adalah bagaimana mengidentifikasi fraud, mana yang masuk abuse, mana yang masuk fraud di dalam JKN yang kita kelola. Yang kedua adalah membangun sistem anti fraud, dan yang ketiga tentu aspek bagaimana memperkuat budaya. Ini saya lebih nanti ingin berkomunikasi lebih intensif dengan Pak Pahala dari KPK, karena ini kami masih dalam proses untuk memperkuat pengelolaan anti fraud di JKN. Yang kedua adalah dalam konteks detection, kita sudah cukup maju di dalam melakukan deteksi, verifikasi fraud, tetapi kita masih tertinggal di dalam fraud investigation, dalam menginvestigasi fraud. Karena seperti yang pada sesi sebelumnya saya sampaikan, BPJS Kesehatan kita belum memiliki special investigator untuk kasus-kasus fraud yang dihadapi oleh BPJS Kesehatan. Berbeda dengan yang tadi dari Korea, tadi bicara secara informal dengan Mr. Hasnul dari Perkeso, dia juga punya special investigator, dan beberapa institusi lain saya rasa juga memiliki investigator khusus untuk mendeteksi dan membuktikan fraud. Dan yang ketiga adalah terkait fraud handling. Ini juga PR besar seperti dari yang sampaikan oleh Pak Pahala, bagaimana kalau terjadi fraud, apa yang harus kita lakukan, sanksi apa yang harus kita lakukan. Next. Ini potensi fraud, mungkin juga abuse yang dihadapi di dalam pengelolaan jaminan kesehatan, dalam mengelolakan social health insurance Indonesia. Ada cukup banyak, ada terkait dengan penggunaan kartu yang palsu, yang bukan kartunya sendiri, tapi dipakai untuk memperoleh akses pelayanan kesehatan. Ada pelayanan yang unnecessary, seperti tadi yang disampaikan oleh Pak Pahala, ada juga gratifikasi. Kemarin alhamdulillah ada satu staf dapat penghargaan karena membalikan gratifikasi ke KPK, Pak Pahala, nilainya cukup signifikan untuk staf. Kemudian ada juga klaim yang palsu, kemudian readmisi terkait dengan pantom prosedur, pantom billing, dan lain-lain. Dan ini semua sebagian besar bukan lagi potensi, tetapi sudah terjadi. Sebagian besar jenis-jenis fraud ini sudah terjadi dan sudah kita temukan, kita hadapi di dalam penyelenggaraan CKN. Dan penting menurut saya, yang pertama-tama ketika kita bicara fraud adalah apa itu jenis-jenis fraudnya. Nah, kita coba mengidentifikasi ini jenis-jenis fraud yang dihadapi oleh CKN dengan sistem pembayaran kapitasi dan CBGs, DRG. Ini jenis-jenis fraud yang kita hadapi. Sebagian besar bisa kita deteksi by system. Tapi sebagian lagi kita belum dan memang tidak mungkin bisa dideteksi by system. Seperti contoh pantom billing, ya itu kita secara sistem kita belum bisa mengembangkan ini bills atau claims yang diajukan ke BPJS Kesehatan ini benar atau tidak. Ini tentu perlu ada investigasi, on-site investigation untuk membuktikan ini ada pasiennya atau tidak dan segala macam. Next. Nah, hal kedua ketika kita sudah mengidentifikasi jenis-jenis fraud yang tadi sudah kita identifikasi, mudah untuk mencium adanya fraud, tetapi susah untuk membuktikan itu fraud. Ini problem yang menurut saya dihadapi oleh kita. Kita bisa mengidentifikasi ini fraudnya, ini, dan kita mencium bau-baunya ada. Tetapi sulit untuk mendeteksi dan membuktikan bahwa itu ada. Ini menurut saya problem di dalam fraud. Yang kedua problem juga Pak Pahala, ini juga mohon dukungan. Ketika kita sudah mendeteksi, mendefinisikan ini fraud, dan kita sudah mendefine juga bagaimana cara mendeteksi fraud. Persoalan berikutnya ketika kita sudah temukan apa sanksinya terhadap masing-masing jenis fraud. Ini juga masalah yang kita hadapi dari sekian jenis fraud yang tadi. Jenis sanksinya itu seperti apa? Karena selama ini BPJS Kesehatan tentu masih terbatas di dalam mengenakan sanksi. Sanksinya adalah lebih kepada pemutusan kerjasama dan mengembalikan uang. Nah, barangkali ada sanksi-sanksi lain yang untuk meningkatkan deterrent effect supaya fraud itu tidak terjadi. Ini PR. Nah, hal yang kedua setelah kita mendeteksi jenis fraud, seperti apa, membuktikannya bagaimana. Yang kedua, menurut saya yang juga penting adalah legal framework di dalam pengelolaan anti fraud. Legal framework itu baik mencakup dari pencegahan, prevention, pendeteksian maupun ke penanganan, handlingnya. Penanganan itu tentu akan terkait dengan sanksi yang diberikan. Yang tadi saya sampaikan, yang sanksi ini yang kita belum mengelaborasi lebih banyak. Karena menarik tadi yang dipaparkan oleh Korea, ada ada pasal-pasal yang kelihatannya peraturan dari National Health Insurance Korea sendiri yang membuat juga sanksi terkait fraud. Nah, kita belum apa boleh atau tidak, mungkin dari KPK, dari kejaksaan nanti bisa memberikan saran terkait hal tersebut. Kita sudah ada dalam konteks besar penanganan fraud di Indonesia. Tentu tadi Pak Pahala, KPK merupakan satu institusi yang melit di dalam anti fraud, anti corruption ya. Ada juga dinyatakan di dalam Perpres, peraturan presiden, ada juga peraturan Menteri Kesehatan tentang anti fraud. Kita juga sudah membuat peraturan BPJS, mekanisme teknisnya untuk menangani fraud, yang persoalannya adalah tadi, ada kalau sudah masuk ke handling, kalau sudah masuk ke penanganan fraud, ini yang kita masih dalam beberapa hal kita belum optimal melakukan, karena sebagian memang di luar kewenangan daripada BPJS Kesehatan. Next. Nah, yang sudah kita lakukan adalah ini Pak Pahala dan Bapak Ibu peserta, kita sudah melakukan deteksi fraud terutama di penjaminan layanan di bawah Bu Lili. Kita sudah cukup lama melakukan deteksi fraud, pencegahan fraud di pelayanan. Nah, tapi kita belum melakukan pengelolaan fraud secara komprehensif, bukan hanya di aspek penjaminan layanan, tetapi juga di aspek lain, di aspek kepesertaan, di aspek Vaskes, di aspek BPJS Kesehatan dan segala macam. Maka tahun ini direksi membuat satu unit khusus anti fraud yang mencoba memperkuat pola pengelolaan fraud dari mulai pencegahan tentu regulasi, sistem, budaya, kemudian deteksinya sebagian yang by system, yang kita juga pengen perkuat lagi deteksinya bukan hanya by system, karena ada jenis fraud yang tidak bisa dideteksi by system, tetapi harus on-site investigation. Kita ingin perkuat ini, dan kolaborasi, ini kolaborasi dengan berbagai stakeholder terkait fraud ini. Nah, sudah sebenarnya yang tadi disampaikan oleh Pak Pahala, di pusat, di nasional level kita sudah ada tim pencegahan kecurangan, di lead oleh Kementerian Kesehatan, di situ ada BPJS Kesehatan. Di daerah provinsi, di kabupaten juga ada tim pencegahan kecurangan. Di rumah sakit juga ada tim pencegahan kecurangan. PR besarnya adalah bagaimana memperkuat tim ini untuk selalu berkolaborasi, bertukar pikiran, berdiskusi tentang bagaimana mencegah, dan kalau ada kasus fraud, itu bagaimana menanganinya. Di beberapa cabang BPJS Kesehatan sudah intens melakukan kolaborasi dengan tim pencegahan kecurangan di pemerintah daerah. Di situ ada Dinas Kesehatan, di situ ada Asosiasi Vaskes ketika ditemui adanya satu fraud. Namun demikian, begitu masuk ke ranah sanksi, nah ini yang kita masih terbatas. Maka bagus barangkali nanti atas arahan KPK, Pak Pahala, bisa tim pencegahan ini juga bisa melibatkan ya institusi-institusi yang punya otoritas di bidang penegakan hukum, supaya kita lebih mudah ketika melakukan penanganan fraud. Ini yang kita belum lakukan. Dalam konteks fraud detection kita sudah ada review utilisasi, baik yang prospektif, concurrent maupun yang retrospektif kita sudah melakukan audit dan kita juga sudah ada analisis data untuk mendeteksi anomali-anomali yang di dalam klaim terutama. Nah, tinggal bagaimana itu bisa dilanjutkan di dalam aspek-aspek yang lebih maju lagi terkait dengan penanganan kalau terjadi fraud. Next. Hal yang juga penting adalah di dalam membangun kultur ya, budaya, terutama di internal BPJS Kesehatan itu kuat kita memberikan sanksi tegas kalau ada pegawai yang terbukti melakukan fraud, itu sama sekali tidak ada toleransi. Bahkan pelanggaran kecil pun kita ada sanksinya. Maka dalam konteks membangun kultur, kita manajemen sering mengutip apa yang disampaikan oleh Nasim. If you see fraud and do not say fraud, you have fraud. Saya sih ini satu mantra yang bagus karena tidak mudah untuk mendorong orang speak up atau menyampaikan kalau melihat adanya fraud, ya. Dan kita dorong kalau ada fraud itu seperti apa, termasuk kita membangun whistle blowing system, channel-channel pengaduan untuk bisa menerima, menindaklanjuti kalau ada pengaduan-pengaduan terkait fraud. Dan dalam praktek sebagian fraud yang kita tangani itu adalah dari whistleblower, dari pengaduan peserta terhadap fraud yang dilakukan oleh pihak lain. Next. Nah, termasuk tadi di dalam kita melakukan deteksi adalah pengaduan dari peserta. Ini sebagian kita temukan sehingga kita mengetahui oh ini ternyata ada fraud. Kemudian juga kita melakukan audit, ya, audit atau verifikasi pasca klaim, dan juga ada audit khusus kalau terjadi fraud. Sebelum itu kita juga punya unit pengelolaan risiko, manajemen risiko yang mengidentifikasi jenis risiko fraud dan potensi impact besaran dan likelihood-nya seperti apa sehingga kita bisa mendeteksi kemungkinan terjadinya fraud di area mana. Yang belum, sekali lagi, yang belum dalam konteks dilakukan oleh BPJS Kesehatan, dan ini mohon betul dukungan dari institusi lain, dari KPK, dari Kejaksaan, ya, dari Kepolisian, dari tentu juga Kemenkes, dari Asosiasi Vaskes, dalam konteks kita melakukan investigasi seperti yang sudah dilakukan oleh berbagai lembaga di negara-negara lain. Yang tadi saya sampaikan ini bagaimana kita bisa secara efektif melakukan menginvestigasi kalau menginvestigasinya terjadinya fraud yang dilakukan oleh berbagai pihak, termasuk oleh kemungkinan staf yang ada di BPJS Kesehatan. Next. Nah, begitu ada fraud kita menemukan, ini yang selama ini BPJS lakukan, begitu ditemukan fraud, maka yang dilakukan oleh BPJS Kesehatan tentu setelah membahas dengan tim pencegahan kecurangan di daerah, yang di situ ada Dinas Kesehatan, ada Asosiasi Vaskes, dan sudah terbukti ada fraud, yang kita lakukan hanya dua. Satu, mengembalikan, itu Vaskes harus mengembalikan biaya yang timbul akibat fraud, dan mengembalikannya itu dengan memotong pembayaran klaim bulan berikutnya. Tidak dalam in case, tetapi bulan berikutnya kita potong sesuai dengan nilai fraud yang dibuktikan. Yang kedua adalah memutus hubungan kerjasama dengan fasilitas kesehatan. Jadi kita terminate kerjasama yang sudah kita lakukan. Hanya itu dua. Nah, apakah ini menimbulkan deterrent effect? Sebagian tentu menimbulkan deterrent effect. Kalau sudah sampai pada putus kerjasama. Kalau hanya mengembalikan, saya rasa deterrent effect kurang. Nah, ini menjadi problem adalah bagaimana meningkatkan supaya deterrent effect atas sanksi terhadap fraud itu bisa kita lakukan. Mengapa? Karena kalau tadi Pak Pahala menyebut soal defisit, dan itu potensi defisit tetap ada di BPJS Kesehatan, meskipun alhamdulillah sekarang sudah surplus, tetapi untuk jagain supaya secara finansial itu berlanjut, bisa sustain secara finansial, adalah kita harus betul-betul bersama-sama jagain, mengurangi, kalau bisa menghilangkan, meminimalkan adanya fraud. Karena dana yang dikelola oleh BPJS Kesehatan ratusan triliun, miliaran dolar US, dan itu cukup besar. Kalau fraud ini tidak bisa kita cegah, kita bisa tangani dengan baik, tentu akan berpotensi mengganggu sustainabilitas finansial program CKN. Next. Nah, itulah penting kenapa dalam tahapan pencegahan, pencegahan yang dua, yang tiga aspek menurut saya yang penting dalam memperkuat legal framework anti fraudnya, dalam mengembangkan sistem IT pencegahan anti fraudnya, dalam menumbuhkan budaya anti fraudnya. Kita perlu kolaborasi, baik diperkuat lagi kolaborasi baik di tingkat nasional, provinsi, kabupaten. Di dalam pendeteksian juga begitu, termasuk investigasi dan maupun di dalam handling. Kerjasama ini bukan hanya di level nasional, provinsi, kabupaten, but we want to strengthen our collaboration amongst the participants from many countries, how to collaborate, how to make networking, as Soumil and Dr. Basan mentioned, and Prof. Gufron also direct me to make networking on anti-fraud in a social health insurance, on social security network among countries, because in European already has European healthcare fraud and corruption network. In global also already has, maybe in ASEAN, Pak Soumil and Dr. Basan. So we can learn, we can share experience among us. We can learn how to strengthen investigator like in Perkeso. We can learn from NHSO on how to build the IT system, also from Herat about the IT system due to the anti-fraud mechanism. I think that's our presentation. Thank you, Pak Soumil and ladies and gentlemen.
Thank you very much, Pak Mundi. Terima kasih banyak. This was excellent and a very good conclusion to the three presentations that we had. Some very important points that you mentioned, Pak Mundi, that also resonate with international experience. It is easy to smell fraud. It is very difficult to prove and go on until actual prosecution. And many insurance agencies stop at just removing the money, but that is not sufficient deterrent. If we need to really create a deterrent, it should be commensurate with the risk of getting caught multiplied by the amount at stake. And if the risk is very small and the amount is also small, the deterrent is even smaller. So how do we make the deterrent big enough? One of them, as you rightly mentioned, is the risk of losing access to national health insurance, which is a very big risk. So even with a small chance of being detected, that is a good deterrent. So how do we make that deterrent action effective, and how do we also use information technology to make the chances of detecting even stronger, are lessons that are emerging from what Dr. Garg presented, what Pahala mentioned, and what you also mentioned. So a lot of themes are coming together. And I think how do we bring inter-institutional collaboration so that your team that is trying to be a deterrent, even for preventive action, has people who have the mandate for enforcement and can do remedial action right away, is also an excellent idea, and I think worth thinking about. So though I feared that this could be a difficult session to do because it was post-lunch, it looks like the content and the presenters were so interesting and so exciting that everybody is wide awake. I couldn't give my gifts to anybody for feeling sleepy. Well, thank you very much for keeping up that strong support to the session. Let's open it up for questions, and I'm sure there are lots of exciting questions. And I'm going to, only one hand. No, I'm going to see more hands so that I can start. Do we have any online questions as well? Please do write your questions in the chat box, and our team will also record. We have the first question from Professor Ajay Tandon, so we are going to pass it on to him. But while we are doing that, I will also be looking forward to other questions. So please do keep raising your hands as you think of questions. Ajay, over to you, please.
So, thanks very much. Repeating my introduction, I'm Ajay Tandon, lead economist for the World Bank. So in fact, I'm going to also ask Sheena if she can give a footnote to one of my points. So I think one of the points I wanted to raise that in India, which I have not quite seen in other countries, is that they reserve some packages for the public sector, right? Because they're so, especially the ones that they're concerned about fraud in, and I'll ask Sheena if she can give one or two examples. I don't quite remember which ones those are, but many times when we look at the, and it differs by state. So in some states, certain packages are really reserved for only for delivery at the public sector, and I was wondering if something similar of such a strategy to reserve the packages. The other point is, if one steps back, and this is inspired by a discussion I had with Pa Gufran over lunch, in some ways, many countries, what they have done is they've actually removed the profit motive from the health sector completely, right? So that's as a deterrent of fraud. And what do I mean by that, right? In some countries, you're not allowed to, it's like a utility, like electricity and water. So it's Japan and things like that, right? Where your price caps are set, your profits are capped. Like in India, they have for the electricity at the home and things like that. That's kind of removing the entire profit motive from the health sector. And many countries do it in education. They're not allowed to have for-profit universities. Whether that has been considered as part of a sort of a broader package, and some countries have implemented it over time slowly, right, to completely remove that dimension. In fact, in Japan, they regulate the prices so tightly. They're really sort of trying to get at those. So I just wanted to add that into the dialogue, and in future meetings, perhaps to also bring in that perspective a little bit more, that how do you use these other levers to try and remove the profit incentive completely, because sometimes one thinks that health and profit making, somehow it doesn't jive together, right? I mean, I'm not being socialist here, but just thinking that because it's a merit good, it's just something so fundamental that you may want to at least bring that onto the table, to regulate it much more, to limit it much more. And the other thing is, another strategy that many countries do is they also close the benefits package, right? They make it much more explicit, so it's not open-ended. But also they close the price, the reimbursement, right? So that year to year, you're sort of putting a global budget and putting a capitation. So at least from the purchaser's point of view, of course you can change that over time, but somehow you're also removing a little bit of the incentive that providers may have to overtreat and charge, because in the end, even it's a form of price capping also, right? In the end, then the providers also don't quite sort of see it as a sector being flush with resources, and that was the logic behind putting global budgets and things like that in many of the European countries, in Thailand, etc., to again try to regulate and try to manage this growth. But I think one of the challenges that we face in Indonesia and India is that we're not in equilibrium yet, right? We are countries where the insurance is still being expanded, still the awareness is raising, and the year-to-year changes are quite dramatic in terms of utilization rates going up and things like that. We are not sort of like Belgium, where it has had insurance for many, many years, and there's an equilibrium that's formed, so they can look at volume controls and they can see if deviations from that. It's much more difficult in our countries. So some recognition that this is also a period during which we have to allow the system to mature a little bit before we can also think of much more advanced ways in which things. Our incomes are growing very fast, right? India is the fastest growing economy on the planet today, right? 7% per year. In 10 years, the economy will double. That's the rule of 70, right? Indonesia is not far behind now. It's also another very fast growing. So, incomes also keep rising. And also the point there also being, you also have inflation. So also the need to adjust your reimbursement rates in keeping tabs with rising income and rising inflation levels as well. Many countries that I have worked on for 7, 8, 9 years, they don't adjust the tariff rates. Your inflation is 5%, 6%, right? And those things add up very quickly, and you're eroding then your entire system of payment. In some countries, every year your reimbursements are, of course, your inflation is only 2% or 1%, so it's easier to adjust. But that also then adds to the perception that this is not a fair exchange between the purchaser and the provider, and kind of gives license to also commit fraud, right? I mean, obviously you can say I won't accept it, but in other cases they'll say we'll accept it, but we'll find ways to make it up. That, to try and remove some of those issues by adjusting for inflation, by adjusting for the fact that perhaps wages have gone up of the private doctors and things like that. So just recognizing that we are in a different space and may have to have some special tools at play, but just also a suggestion for future things to think broadly about how can you also regulate the private sector much more using a variety of tools that can then help recognize that this is a different sector from it's not the same thing as buying Coke or Pepsi or going to a restaurant, right? It's a different transaction that takes place when you're purchasing health. Thanks.
Thank you very much, Ajay. I see Pa Gufron wants to make a statement as well. We have front row contributions.
Yeah. No, I think it is very interesting, and what Ajay already mentioned. Actually, I would like to comment number 2 and number 3. So number 2, it is not usual as the World Bank suggested, how if not profit health facilities. The new World Bank, this is very good because the World Bank chairman that time was the the Korean descent. He is the Jim Kim, Jim Kim. So I think it is actually challenging, especially in Indonesia, because in Indonesia, the Ministry of Health as the banker. So the way to think is really different with people who are the public policy makers with health background, for example, like public health. It's really different. So as you know that in Indonesia now, we have 3,150 hospitals. 66% are private and mostly are profit-oriented hospitals. And I think it is not in the peak. So I think, as you mentioned, it is not in the equilibrium. So not like in the Belgium, but still going on. And I'm not sure because in the year 2023, maybe the the world will be crisis maybe, or at least the economic tension will be there. So it means the ability and willingness and capability of the community to pay more when you are saying that we have to pay, consider the inflation, that is something that we need to consider also, because this will be a new challenge. And the second and the third about the strategic purchasing. So you mentioning about the global budgets or a type of capitation. Of course, it is good thing, but it is sometimes not easy. We in Indonesia already, over the last 3 years, piloting global budget. And especially when in the city or regency where only district hospital or one hospital, it's very easy. But if many hospital and private hospitals and public hospital and more other private hospitals, then very difficult for the implementation, or maybe you have any idea for that. But for the capitation, of course it is good things, because in Indonesia now we are introducing performance-based capitation system. And that is good thing, because people in the primary health care would like to achieve performance in order to get more money for the more capitation. And the problem is the question whether actually better fee for service, because in the primary health care, especially in public health centers or puskesmas, the quality is not quite good compared to private clinic. So when we trying to implement capitation, it means give less necessary services. So when, give fee for service, but we cap, with cap certain, then which one is better actually? So I think that is one of the, at least discussion or questions. So you can answer my also questions if you like. I think that is all, and thank you very much.
Thank you very much.
I'll also like to take it up. I think Ali Gufran has already, explained a lot of it. Ajay, I think your point is quite valid. We need to take profit out of health, away from health. But there are many such fields which require profit to be taken away from those sectors as well. At present, India is health services are scarce. There is great demand, there is lesser supply, and it is quite inequitable also. The government is investing hugely in health infrastructure now, in the health services, but we also want the private sector to invest. And another dimension to this is that India is also looking at Heal in India. We want people from abroad to come and get, health services in India. So I'm not so sure we can take away, or even the talk of taking away profit from this health sector. But you're right. As long as there is a profit, there is always, an incentive for fraud. But I think the incentive for fraud would still be there, even if profit is taken away from it. So I think we are throwing baby with the bathwater, so to say. Regarding your other point, I think it is important that we look at health in a holistic sense. There is always a chance that there is a fraud or there are malpractices, but that is where the deterrent comes in. That is where we ensure that some action is taken and that is well publicized, and there are people who some examples are created which deter others from doing that. So thank you.
Thank you very much, Dr. Garg. I'll be looking for more questions, but let me just reiterate what was asked. So reserving procedures for public sector, are there other precedents? Shall we be removing the profit motive? Are closed and explicit benefit packages an option? Is there a respite because there is unfair pricing, so it's okay to do fraud? I know all of these are provocative questions, Ajay. I can see your intent, and already some of that has been answered. And a very important point from Pagufran on the need to consider ability to pay and to evaluate performance-based capitation versus fixed capitation as well. Maybe Pa Mundi, if you'd like to respond at this point, or Pa Hal.
I just little comment for Ajay concern about two things. First, as Prof. Gufron mentioned, that BPJS Kesehatan is not for a profit institution, as Pak Ajay also know. So BPJS Kesehatan not seeking profit in managing the CKN, but because our health facilities, 60% of hospital in private insurance, we understand if a private health facilities, not private insurance, private hospital. So we understand if private hospital also need the profit, but the problem is we don't want that any profit maximization, but normal profit. I mean that hospital need to grow, BPJS Kesehatan also need to sustain, people also need to get the health services, quality health services. This is how to make equilibrium. Because if we tolerate the profit maximization, it is difficult to us to maintain the sustainability of program CKN. But if the tariff is not increased, it is difficult also for a hospital to grow normally. But the problem is any correlation between tariff and fraud. Is it because the tariff is not sufficient, so any fraud in CKN? I think this is the question. I don't think so. Yeah, I don't think so, because as you know that there is no hospital, there is no health facilities is bankrupt when they cooperate with BPJS Kesehatan. Most of them is growing. It's growing, not only the services, but also the revenue. Health facilities also are growing. But when we are talking about the increasing of tariff, it is the many issues for that. And the question is tariff of JKN is sufficient or not sufficient? Should be increased or not should be increased? We BPJS Kesehatan, as Prof. Gufron mentioned, I think that we actually also support to increasing the tariff for health facilities, because we need also that health facilities health industries also need to increase together with CKN. So, but there are two questions in the increasing of tariff. First, that the increasing of tariff, I think better if based on the costing study properly, because to answer whether the tariff should be increased or not, I think the objectively answer is should be based on the costing study. The costing is increased or not. The costing is sufficient or not, I mean the tariff. The secondly is we want that the increasing of tariff of JKN also can push the increasing of quality. Not only the cover of the cost, but also the quality. The quality of services, health services in Indonesia, I think still the big question, the big homework for us to increasing the quality. So why BPJS Kesehatan also need to increase the tariff, because we need to improve the quality. But our worries is if the tariff increase, but the fraud management is not strong, I mean many hole in the fraud, it is a double burden for CKN, I think, because the cost can doubling, not only because the tariff increase, but also the fraud happen in the CKN program. I think that's our little answer. Thank you.
Thank you, Pamundi. Pahala, would you like to come in, Pa?
Yes, Pa, thanks for this opportunity. I agree, Pa, that the health sector it's kind of a unique sector, so it is not about whether hospital can make profit or not, or BPJS can make profit or not. It is wider than that, because in this sector in Indonesia, we realize that in some areas, asymmetric information is a key. I mean, we as people come to the health facilities with zero information. We are dealing with, let's say, a medicine management, for example. Years ago, whatever the doctors put in a prescription, we agree and we buy. Then we realize that generic medicine is equal, more or less, to the, let's say, prescribed. It reduced a cost of medicine significantly due to asymmetric information. Now, I thought BPJS Kesehatan is the biggest players in these sectors. They can set a direction of the Indonesia health sectors due to of their size. I saw in many hospitals of revenue comparing to the years ago. And if I recall, one of the study at the Gajah Mada University, they said that using a current claim tariff, it's enough, it's sufficient to them. But again, we have to accommodate kind of like another layers at the people who's able to pay more and request kind of like a better quality of the service. That's why we said the coordination of benefit must be realized soon with the private insurance. That's the way we can combine kind of like a government obligation to the most of the people, and at the same time for the, let's say, middle income above, they can get a better quality if they need. But among those, we have to ensure that asymmetric information is not there. So if the people come, they know that they have to pay more and they want to do that, fine. But if they know that I can have this service under BPJS Kesehatan scheme, the hospital or a health facility must provide that. If it is not, it's a kind of a fraud. You mentioned that, okay, it's not available under BPJS while it is available, so that's a fraud. Or they say that, okay, here is under claim of BPJS, you only have these 5 pills, while they claim in the package it should be 10, for example. We saw a lot of these practices, and we think that as the BPJS Kesehatan is the biggest players, you can set direction for these sectors. Combined with the Ministry of Health as a regulator, I guess at one side, the people must be educated. Literacy of this facility must be at the level that the people can choose. And if they choose, they're able to pay more, that's fine. You make profit out of it. But if they pay for BPJS Kesehatan, we have to provide a standard. And to KPK observation, we believe that BPJS Kesehatan has changed the way industry works. Efficiency, that's the one that we look at very, very significant, because it changed the doctors, the hospitals, all the system works now to be more efficient. They only take a medical treatment the best they can do, the most efficient they can do due to this limited claim, for example, anyway. So I think make profit or not, it's clear that BPJS Kesehatan not allowed to make profit at all. But at the hospital level, if the people aware and they consciously choose to pay more and able to pay more, we have to let them do that. But for the most of kind of like a people covered by BPJS, we have to provide equal and standard treatment to them. So that's from our side, Pak. So fraud will be there once the tariff is too low. Agree with that. But if it is too high, it's kind of like we who's a double fraud at a time. The first fraud by system, and another one the fraud by practice. So that's from my side, Pak. Thank you.
Thank you. Thank you very much, Pahala. I see that Pak Gufran already wants to come in. Yes, please.
No, I just would like to thank for Pahala Nainggolan, who really always committed from the beginning of the development of national health insurance in Indonesia. And of course, what he mentioned actually about the asymmetric information, it is very important, but the problem is it takes time. How to, empower the community in order to understand and to know a little bit about health. So I think if the community have enough information and they have choices, then I think it is a good thing. But again, when we are trying to, I think what Pak Pahala emphasized, that BPJS should not be profit-oriented organization. Yes, now we are not for profit and we are the biggest player, as Pak Pahala Nainggolan mentioned. And now the problem is the rich people, because the rich want more. And the problem is that if we agree that we should have standardized standardized benefit package, but the problem is we have no yet clinical guidelines. And Minister of Health actually should develop clinical guidelines, and thanks for World Bank for helping developing the clinical guidelines. And of course, like in India actually, how actually we make in the middle between public-private mix. So as mentioned also by Pak Pahala Nainggolan, actually now BPJS shape the way of the business in health industry. That time, before BPJS was established, specialists can make the tariff based on their opinion, so and very high. But now the tariff should be negotiated between health association, health facilities association, and BPJS. And Ministry of Health will determine the standard tariff. But if the tariff is too low, like Pak Mundi mentioned, that is also a cause of the frauds. Then, of course, we have to make, like Ajay also mentioned, the enough tariff. But as mentioned also by Pak Mundi, now in Indonesia, no one single hospital bankrupt because give services or MOU with BPJS Kesehatan. Because each hospital in Indonesia now, approximately more than 80% the patients from BPJS. So they are life of the hospitals depend on the BPJS. And so now again, the biggest player and more powerful, maybe more powerful than other institutions to make the game of the health industry in Indonesia. I think, thank you Pak Pahala Nainggolan, I think since the beginning, and thank you, and we have to work more because too many homework that we have to solve together. Thank you.
Thank you, Pak Gufran. Economists like Pa Ajay and Pa Zelalem call it the monopsony power of a single payer, the ability of the large purchaser to be able to really command the market. And with that power comes a lot of responsibility, because you can shape the cost structure, you can shape the quality structure, but if you do not do it, then you also are taking that opportunity away. So I think that responsibility is where Pahala and BPJS have really come a long way, and we need to continue that journey now, even more on the quality dimension, in addition to the cost dimension, where I hope that this clinical pathway rhetoric that we heard since morning, it's been coming again and again and again. I hope we can build upon that and really make that a fundamental building block. I also wanted to say that the health insurance agencies, whether they be the National Health Authority or BPJSK or NHSO or HERA, are really the market makers here, and they are much bigger than what we traditionally called PPP hospitals, for example. These have made purchasing from the private sector seamless. 3 decades back, how many countries could have imagined that we could be working with private sector so seamlessly and being able to create services for some of the poorest people in private hospitals and being able to pay for them. And I think the growth of institutions that are aiming towards universal health coverage in the last few decades has really shown that we can do that public-private engagement at scale using rules of the game and being able to still deliver a lot of welfare benefit to even some of the poorest people in the system. I just wanted to also maybe be a devil's advocate to the discussion on whether it should be profit or not. I would just give an example, maybe again, because we were discussing that during lunch with Dr. Garg. Medical education in India is not for profit. Is it beyond fraud? I will not make any comment, but because you eliminate profit, people find ways to manage. Some of the biggest hospitals in India are registered as charitable, not-for-profit institutions, and are some of the most expensive hospitals in the country. They find ways to charge, and they find ways to use that money even if they're not reporting it in a balance sheet as profit. They call it a surplus. And there are ways in which they can still distribute that money among their doctors and among themselves. So I think it's very difficult to eliminate incentive structures. Even public hospitals in many countries are known to have committed fraud under health insurance programs. So it's about the incentive structures, and it's about trying to see how the incentives can be aligned to public policy rather than trying to say whether it should be for profit or not for profit. And I think that's where some of our advantages lie. If we can make the incentives for profit institutions to deliver more quality services at an affordable cost at a higher volume and still take more fair profits back, I think we are using that instrument that economics offers us in a good way. Let me also just introduce another element, and I see a hand here, between fraud, abuse, and moral hazard. You know, when I go to a restaurant and I'm offered two types of payment, I can pay by buffet, pay per head, and then eat as much as you like, or I pay a la carte. I will be charged for each item. In which context am I likely to fill my plate too much and waste food? Buffet. Insurance is a buffet. My plate, I am not paying for my plate because it is all prepaid. Would you call it fraud? Actually, not really. It's moral hazard that is natural in the way this is structured, but I do not realize the wastage element that it creates and ultimately increases the cost structure for the system. And I think that's where some of this moral hazard dimension needs to be managed through careful design, and that's what programs are doing.
I would just add that, you know, it is an oversimplification to say it's the plate has been paid for, because here the patient is also a stakeholder and the healthcare provider is another stakeholder. So in fact, there are two people holding the plate. So we really need to understand that.
We have a lot more complexity because the decision maker here is not the patient, but the provider, and that adds another level of complication. But I simply wanted to say that the moral hazard element exists, whether it's a willful fraud or not, and I think that also
hold on, Samuel. So before you go away with the impression that moral hazard only affects from the demand side, there's also moral hazard from the supply side. And if you have a system that has out-of-pocket spending, the flip side, you will get over-treated and over-tested and over-thing. This is the information asymmetry that they're talking about.
Yes.
So you know, it's not just moral hazard from
On the demand side.
demand side. There's even worse moral hazard from the supply side. And if I may say, I add one more point. I want you to leave with some of the innovations that are happening globally. You're making a very interesting point that made me think about the profit motive and how to get it. So there are experiments going on currently as we speak, including in the US, including in Belgium, including in Germany, where imagine that, you know, I have a network of primary, secondary, tertiary care facilities, and then I pay $100 per year to cover Pargofron to that sort of network, right? So now, what is the incentive of the providers? The incentive of the providers is to keep Pargofron healthy, so he doesn't utilize. And so they get to keep the $100. It's just simplified logic, right? However, it's turning the whole health system around, saying that, you know, it's called global capitation, basically. So the providers get to keep. And originally, what is the name of that company in the US?
Kaiser Permanente.
Yeah, originally it follows that logic of Kaiser Permanente, or HMO organization. But it's a very powerful way if it can, you know, if you can succeed it with, you know, without skimping on care, without doing that, the healthier you are, the more profit the provider makes. So I just want people to leave with also that thought that you know, how can we, you know, turn it around.
And also look at long-term costs by keeping people healthy today, like early coverage of NCDs, saving money 10 years down the line.
And they get to keep the money, Somil. That's the key point.
Exactly.
Profit motive.
Yes.
So I want Dr. Garg to dream about this tonight.
No, I'm already thinking about it. I think then it may lead to under-treatment and denial of treatment. So we'll maybe discuss it. In a large country like India, in the rural areas, you know, there could be denial of treatment or there could be under-treatment. So we really need to look at that. But it's a good model.
Can we get a mic here? Sheena, is there anybody else who would like to ask a question? This is my last call, because I know that we have exceeded the time, but this is such an exciting session. It's on autopilot mode. Doesn't even need a moderator.
I think that's right. I think, and this is really a catch-all session where we are really taking the broader issues on fraud management. One of the things that, you know, we had done a study looking at 8 country experiences in terms of fraud management. And what we had seen in that, there are very few countries that actually look at a pre-authorization for hospitalization care. And one of the things that I did want to put on the table is in terms of, you know, since we are working in health and we know prevention is the best cure, how effective is pre-authorization for prevention of frauds? I think that's one question. The other aspect that we haven't really touched upon as much, I think in the morning session, you talked about, Natalie, in terms of technology is important, but human resources are very important. And that's the other thing which we see in terms of, if we look at the capacity for different agencies to, you know, in terms of the implementing agencies for in different countries, what is the kind of management capacity that is needed? And I can say that for India, you know, when we looked at some of these global experiences, what we realized, though there were 20 different, you know, states in India that were implementing different kind of insurance schemes for the states, fraud was not even defined at that point. There were no even units that were looking at, there were no capacities in the states which was looking at fraud. And in fact, one of the things which PMJ has done is to look at national anti-fraud units, establishment of state fraud units, but the capacities that are really needed to implement this. And that becomes a deterrence, because technology is important, but how do we sort of make sure that we have the right human resources to implement that? The third element here, and I think Somil, you touched upon that a little bit, in terms of most of the efforts that we have in panel, both public and private hospitals. My own experience is that we really have different set of standards that we use for public and private hospitals. And since fraud can happen in both, how do we sort of really make sure that there is a level playing field? But because in some ways I do feel because we are looking at a lot of times taxpayers' money being used, etc., we do look at the private sector with suspicion to begin with. Even though we are signing up on this together, we are a little bit more lax with public sector. In terms of want to actually take that debate a little bit forward on that aspect. And the last point is on the deterrence part. And on the deterrence part, prosecution may be the last bit that one looks at. But we know in terms of the kinds of laws that are there, the time that, the evidence that you need to generate, and the time that it takes to prove something. So, in terms of de-empanelment, suspension, some of these things we know do work. What could be some other measures which may be a little bit more innovative and can add to acting at stronger deterrence? So these are just some thoughts that I want to leave with. Thanks.
Thank you very much, Sheena, and I think those thoughts were also an excellent summary of what we would have wanted to conclude with. I know we are well beyond time, so I'm not going to stretch with any further summary, but just take the opportunity to thank Dr. Garg, Pahala and Pamundi for an excellent session which has provoked so much of thought in our group, and I think we are all very much energized despite this being a post-lunch session. So all the more credit and a big round of applause for the excellent panel. Thank you very much.
Thank you. Thank you.
And with that, I pass it on back to the moderator.
Yes, ladies and gentlemen, once again we have round of big applause for such an interesting session, and this is the last panel discussion this afternoon. We would like to invite our moderator and speaker. Please stand here in front of the stage because we are about to continue our today's agenda with the giving of token of appreciation. Therefore, we would like to invite our speakers that present here in person and also our moderator for the first panel and the second panel session to join us. We would like to invite Ms. Lily Krisnawati, Ms. Piang Hatai Ingun, and also we would like to invite Mr. Doni Hendrawan and Ms. Natalie De Wolf to join us for this session, please. And now please allow me to invite Mr. Ali Gufron Mukti, President Director of BPJS Kesehatan, to giving the token of appreciation and certificate to all of our respected speakers and moderator for this session. Now we would like to invite Mr. Ali Gufron to give the token of appreciation for NHSO. Now, ladies and gentlemen, we would like to invite Dir Jampalkes to join us for the giving of token of appreciation. We honorably invite NHA. Now we would like to invite Mr. Mundi Harno to join us and receive the token of appreciation and certificate. Our moderator, Ms. Nathalie De Wolf, please. We would like to invite after this to join us to receive the token of appreciation and certificate. We would like to invite Mr. Doni Hendrawan. We would like to invite Mr. Somil Nakpal to receive the token of appreciation. And now we would like to invite Bapak to join the speakers and moderator to have a photo session. Ladies and gentlemen, can we have a big applause for all of the speakers and moderator? We would like to invite all of the speakers and moderator to please have a seat, and we would like to invite Mr. Ali Gufron Mukti, President Director of BPJS Kesehatan, to deliver the closing remarks and conclusion for our conference today.